when sunshine is in our hearts. Okay, it's a great day. You have a seat. It's a great day. Awesome, awesome, awesome. Welcome, welcome, welcome everyone who are here in this room, and for those who are online, welcome, welcome to Newark Community Health Center's 8th Annual Symposium. Today, yes. Today is an honor to have some very distinguished speakers in the house. All of them are ready to give you information and hope for the future. We just want to welcome First Lady Tammy Murphy, Mr. Dennis Gonzalez. I'm going to introduce him in a moment. Ms. Clarissa Lawson. Our panelists who are sitting here, and everybody's going to get an introduction soon, all right? But we must first start by just welcoming our key speakers. I also want to say thank you to our partners sitting in the audience, and that includes Columbia Bank, RWJ Barnabas Health, and Beck Israel are they in the house? Henry Shine Medical, Aetna, Horizon, Image Care Radiology. I hope I'm calling all those names. Later today, but it's very important that when we start that we acknowledge some key people who are doing an amazing job for each and every one of you. It's with great joy that NCHC continues to serve the community. This year marks 38 years of providing affordable quality health care to people in Newark and the surrounding communities. From the time that NCHC was incorporated on October 2, 1986, we have pushed the bounds of healthcare, utilizing population health strategies and now social determinants of health for disease prevention and reduction of healthcare disparities in the community. We are currently the largest provider of comprehensive partner care services for the uninsured and medically underserved population in the country's most densely populated cities. In 2024 now, we have served over 47,000 patients in Newark and surrounding communities. Of which 36,000 of them are women. Of which 30,000 of them are at 100% or below poverty level. Clap that too. It means we are reaching out to the people who need the care and services. That's amazing. NCHC is constantly listening to the people and learning to provide culturally sensitive health care to all who come through our doors. We have learned that women face diverse and unique healthcare concerns across their lifespan, which may affect their overall health and wellness. Despite the recent advancement in women's health care, because there has been advancement, and you're going to hear it from the people at the podium, statistics reveal that there is troubling trends with a number of issues, including that pertaining to maternal mortality from pregnant-related complications. Moreover, there were low prevalence of prenatal care in the first trimester, but it means that Black women are 43% less likely to start prenatal care in the first trimester. And they have 16% less chance of gaining access to postpartum care in this community. While 9% of white women initiated mental health care, the rate for Black women and Latinas was 4 to 5%. It's a problem. So the odds of initiating mental health treatment after delivery were significantly lower for Black women and Latinas. One more. Breast cancer screening rate was found to be higher among Black women. However, breast cancer mortality rate was 40% highest among them. So as we say, there are some improvements. However, there is still a negative impact on Black women. For cervical cancer screening rates was lower in non-Hispanic Black women compared to non-Hispanic whites. The literacy rate can significantly impact women's health by posing barriers to understanding crucial health information. The literacy rate impacts how people of color and minority are able to navigate the healthcare system and the ability to care for their children. This is very interesting. Social determinants of health plays a vital role in women's health. On the average, 28% of women are food insecure and 8% are house insecure. These insecurities can create significant physical, mental, and emotional challenges. Lack of access to nutritious food increases the risk of malnutrition, obesity, and chronic diseases like diabetes, hypertension, and cardiac disorders. Insecure housing can lead to heightened stress, anxiety, depression, hereby impacting mental health. This also exacerbates existing health conditions and hindrances in access to services. These healthcare disparities occurred than before, haven't you? And so, while you know them, we're not going to dwell on them. We want you to understand that these disparities underscore the urgent need to target interventions and policies to ensure equitable access to quality health care for all women. This symposium that we have today and for every year to come is dedicated to celebrating the resilience, the strength, and the well-being of women in this community. Embarking on this journey of discovery, dialogue, and empowerment, we seek to address the multifaceted dimensions of women's health in the modern age. Women's health is not merely an absence of illness, but a holistic state of physical, mental, and emotional well-being. So today, we're going to have a very amazing interaction with leaders in New Jersey who are going to talk to you about what they see is happening in our community and what they are doing about it. So, most importantly, I'm going to introduce the First Lady, Tammy Snyder Murphy, and I noticed in her bio that is posted everywhere, it says born in 1965. She's proud of it. I just celebrate the birthday. Born in 1965, Tammy Snyder Murphy is a native of Virginia and a graduate of the University of Virginia with a bachelor's in English and communication. She and her family reside in Monmouth County, New Jersey. But Newark, she's no stranger. There you go, she's always here, always here. Tammy and New Jersey Governor Philip D. Murphy has been married for 30 years, and together they have 4 children: Josh, Emma, Charlie, and Sam. A transformative experience for the Murphy family was proudly represented in the United States in the Federal Republic of Germany from 2009 to 2013. Tammy individually and together with her husband spoke and led on behalf of the United States of America. She chaired meetings, gave speeches, and hosted meals and receptions, strengthening our nation's relationship with a critical ally while impacting the lives of thousands of Germans and Americans. Upon returning to New Jersey, Tammy and Phil realized that the incredible state they call home needed bold new leadership. Together, they founded a think tank to explore ways to help grow the middle class and jumpstart New Jersey's economy. During the campaign transition, and now as First Lady, Tammy has been energized and inspired, traveling the state. She comes here all the time. And she meets New Jerseyans to hear their concerns, utilizing her experience in the private and non-profit sectors to work through policy, ideas, and solutions. Over the years, Tammy has worked with non-profits, a think tank, and other organizations focused on the environment, education, healthcare, youth and family services, as well as the arts and transatlantic relations. She currently serves on the board of directors and charter member of the Climate Reality Action Fund, an organization founded by former Vice President Al Gore. Do you know she speaks German and some Italian? Awesome, isn't it? Awesome. Oh yes, oh yes. I'm telling it all. This is very important. This is very important. Very important that you know these things about the First Lady. As First Lady, Tammy's policy initiatives focuses on infant and maternal health. And you know that because she's been at it from the time she took office, and she's still at it today, and she will continue to be at it with infant and maternal health. She also focuses on climate change education and fostering women-owned businesses throughout New Jersey. She has worked to create family festivals across the state to increase access to resources for mothers, children, and families. She has worked with the New Jersey Department of Education to incorporate climate changes through K-12 state education in order to better prepare our students for the future economy. She has partnered with the New Jersey Economic Development Authority to create angel investing in women-led business. She continues to be a partner to Phil as she works with Lieutenant Governor Tashia Wade to tackle the formidable challenges facing New Jersey and its incredible residents. So on behalf of the Board of Trustees who is here today, and they're going to raise their hand, so you see them, or Board of Trustees, on behalf of Board of Trustees, the staff at Newark Community community health centers and the community here today and in Newark, I would like to present the First Lady, Ms. Tammy.
Good morning, everyone, and happy National Women's Health Week. Dr. Clark, Pamela, my friend, I would just like to say thank you for that introduction and for your incredible partnership as the President and the CEO of the Newark Community Health Center. I can assure you all, my introduction will be longer than my speech, so don't fret. It is my honor to welcome all of you to the 8th Annual Women's Health Symposium. And I want to thank the Newark Community Health Center for putting together this important program. I obviously also want to recognize Dennis Gonzalez, the Executive Officer at the U.S. Department of Health and Human Services, who is with us today to give us his perspective from the federal level. You may expect today's discussion, which is centered on maternal health, to focus on the importance of prenatal care. And while ensuring every mother has access to high-level prenatal care is incredibly important, it is far from being the primary factor in determining a mother's experience throughout pregnancy, labor, and delivery. In fact, understanding the extremely complex web of factors that affect a mother's health was an essential part of launching our maternal and infant health initiative, Nurture NJ. When Phil first took office in 2018, New Jersey was appallingly ranked 47th out of 50 states for maternal mortality rates. Even more disturbing, this ranking was the result of an extreme disparity in outcomes between mothers of different races. At that time, a black mother was 7 times more likely than a white mother to die from pregnancy-related complications, and a black baby was 3 times more likely than a white baby to die before his or her first birthday. Hispanic mothers were 3.5 times more likely to die of maternity-related complications than white mothers, and the mortality rate of Hispanic babies was nearly 1.5 times that of white babies. As a mother, and simply as a fellow human being, I urgently wanted to change this, and in 2018 began a year-long listening tour across the state to really better understand the landscape of maternal and infant health. I met with health systems, some represented here today, government departments and agencies, physicians, doulas, community organizations, church leaders, mothers, and families, and more. The result of those conversations is Nurture NJ, our all-out effort to strategically transform a system that has historically failed our mothers and babies of color. After its launch in 2019, we quickly began work on the Nurture NJ Maternal and Infant Health Strategic Plan. Because everything, as Dr. Clark just said, from our living situation, our stress level, our nutrition, our relationships, access to transportation, and more, really works together to build a complex web of factors that influence our overall health and well-being. Because of all that, our approach to solving this crisis needed to and still needs to be equally broad in scope. And since the release of the Nurture NJ Strategic Plan in 2021, we have completed or made headway on over half of its 80 recommendations, including becoming the 2nd state in the nation to expand Medicaid coverage for a full year after childbirth, and the 3rd to expand Medicaid coverage to include doula care, and the 1st to ensure that those doulas are culturally competent. We also established the 1st in the nation Maternal and Infant Health Innovation Authority, and are building a groundbreaking Maternal and Infant Health Innovation Center in Trenton to continue this work past our administration. I am thrilled to share that just last week, the Economic Development Authority entered into a memorandum of understanding to purchase in downtown Trenton some land that will be used for our Maternal and Infant Health Innovation Center. The site was chosen specifically to ensure that it is accessible to as many mothers in the community as possible. And importantly, we have worked closely with our partners at the John S. Watson Institute at Kane University on a 2-year community engagement stakeholder process to ensure that Trenton community voices guide the creation of this center. Further, 2 of our most recent and I think exciting achievements are the launch of our Universal Nurse Home Visitation Program for new moms and families and our doula access bill. We've actually passed over 60 pieces of legislation since 2018 in this space, but I have to tell you, the Universal Nurse Home Visitation and doula bill are really seriously going to have a lot of impact, so I'm really excited about them. But together, these policies are work to target the most critical time period for complications, labor, delivery, and the first few weeks postpartum. Our doula access bill ensures every mother has the right to have a doula present in the delivery room if she chooses. The support of a doula is proven to reduce birth complications, lower C-section rates, improve maternal mental health, and so much more. Quite frankly, if I had even known what a doula was when I was having my 4 children, I certainly would have had one. Similarly, our Universal Nurse Home Visitation Program, known as Family Connects NJ, supports mothers during the most vulnerable postpartum period. This program is available to every single new parent in the state. It does not matter if you are undocumented. It does not matter if you have health insurance, and there is no income requirement. This program is universal and it's free, and it will be a game changer. Through this program, a nurse will go to a mother's home within 2 weeks of bringing home her newborn to ensure both mother and baby are thriving. The nurses can help with lactation, identifying any postpartum mental health issues, connecting parents with resources, and so much more. Right now, the program has launched in Cumberland, Gloucester, Middlesex, Mercer, and yes, right here in Essex County. Starting January of next year, it'll be available in Somerset, Sussex, Passaic, Hudson, Bergen, and Ocean counties. And it will continue to roll out in January of each year until it's fully available statewide by January of 2027. I want to stress that this groundbreaking and common sense program is already available here in Newark and across Essex County. So please spread the word that parents can easily sign up for these free in-home visits at familyconnectsnj.org. Some hospitals even have direct sign-up available while moms are still recovering from labor. Essex County Family Connects nurses speak multiple languages, including English, Spanish, French, Haitian Creole, Brazilian Portuguese, and Twi. I am thrilled to say that the number of families served has increased every month since we launched the program in January. The most common referral that the nurses make is for material support, meaning the family could benefit from assistance with diapers, a car seat, a bassinet, or even food, housing, and transportation, which I know is what all of you around this room are providing, so thank you for that. In addition, 16% of the visits conducted in Essex County so far have resulted in the nurse identifying a symptom that required a referral back to the prenatal or pediatric provider. This includes signs and symptoms of preeclampsia, post-cesarean infection, and infant feeding concerns. These complications have the potential to be life-threatening. So it is very possible that Family Connects nurses have already saved lives. The potential for this program to directly impact both the health of mothers and babies in the postpartum period, as well as to connect families with support programs, is truly unlimited. And I would welcome any support you all can provide in spreading the word, both with the fact that it exists and also that signing up is easy and free. We have worked incredibly hard over the past 6+ years to identify policy solutions that will help us reach our goal of transforming New Jersey into the gold standard for maternal health care. But discussions like today, raising awareness of our crisis and our effort to solve it, remain a critical part of our strategy. And although we have much more work to do, I am pleased to share that over the course of these past years, since the beginning of this administration, New Jersey's maternal health ranking has risen from 47th in the nation to 27th. As we continue to work toward our goal, I am incredibly grateful to the many partners across the state who have joined us in this mission, including all of you who have taken the time to participate in today's important program. Together, we will make New Jersey the safest and most equitable state in the country to deliver and raise a baby, and I thank you for having me.
It's raining in NCHC, always brings sunshine. So on behalf of the Board of Trustees and everybody here and in Newark, the surrounding community, thank you for the hard work that you do. We're truly grateful. Who are you ahead first? Thank you. Well, I was going to ask you, oh Lord, I think it's awesome. Okay. Sorry, that's
Up to you.
Thank you so much. Thank you very much. Have a safe way.
So bless you.
We're a healthcare organization and we're concerned with everybody's safety, and so we ask that she travels safely back to her next destination. And don't get your blood pressure up. Thank you so much. Awesome. We're going to keep moving, and I'm going to introduce somebody before we start the panel. But again, I did get a chance to have the Board of Trustees. Could you just stand so people see you so we can say thank you? Now you see them. It's very important. NCHC is led by the most amazing board. They are very engaged and they are very concerned about your health. And so they make sure that the health center is run effectively, smoothly, and that we hire culturally competent staff to get the job done. So we want to tell them thank you so very much for their hard work. Now, of course, I'm going to introduce to you Mr. Dennis Gonzalez, who is the Executive Officer out of the Office of the Secretary, Region 2, U.S. Department of Health and Human Services. In 2004, Dennis Gonzalez was appointed the Executive Officer, Chief of Staff of the United States Department of Health and Human Services, Office of Intergovernmental and External Affairs, Office of Region Director in Region 2, which is New York, New Jersey, Puerto Rico, U.S. Virgin Islands, and 8 federally recognized Indian tribes. That's a lot. That's a lot. Thank you so much. As the HHS Executive Director for Region 2, Dennis is the most senior career HHS official in the region. He serves as the primary aide and advisor to the HHS Regional Director and represents the office of the secretary, and it helps to ensure that all HHS priorities, initiatives, and programs are executed appropriately and in the best interest of the constituency that HHS serves. Dennis works closely with local and national partners and stakeholders in the areas of public health, access to primary health, mental health and addictive services, family and children's services, homelessness and emergency management, among many other things. So just like how his title is very long, his duties are even longer. He has a strong working relationship with the federal, the state, and local elected officials throughout the entire region. Since February 2018, Dennis has served as the chair of the New York City Federal Executive Board, FEB. The New York City FEB is one of the largest in the country, with over 50 federal agencies representing over 30,000 federal employees. He was born in Patterson. Dennis was raised and educated in Puerto Rico, and he began his public service career 35 years ago as an intern in the office of the governor of Puerto Rico. Since then, he has served in the administrations of 4 New Jersey governors and under the leadership of 7 secretaries of the Health and Human Services. Let's give him a warm welcome as he presents.
Good morning, everyone. Good morning. Buenos dias. Absolutely delighted to be here this morning with all of you. I want to thank my dear friend Pam Clark, Dr. Pam Clark, and her team at Newark Community Health for this invitation and this opportunity. I want to thank, whenever I do an event with a community health center, I always make sure to thank the board members. Sometimes the board members don't get the credit that they deserve. And, and I like to say this as a joke, but it really is serious. Board members are actually the people responsible to us for the health center. So if Pam screws up, which she never does, but if she does, then the board has to respond to us for Pam. So the board plays a very important role. And of course, they're all volunteers. So I always take time to thank board members for their service. I also want, and I know she left, but I want to thank the First Lady because she has been at the forefront of spearheading a number of initiatives in collaboration with us at the federal level to promote women's health, maternal child health here in New Jersey. She's been actually a model at the national level. Some other states have copied what New Jersey has done under her leadership. So even though she's not here, I hope the message gets to her that we at HHS, at the federal government, truly do appreciate her leadership here in New Jersey. It's nice to be back here in Newark. I worked over 30 years ago. I started my career here in New Jersey with the state of New Jersey. Of course, I was very, very young. I was in my teens then. And my last job with the state was actually down the road here on Mossy Street. I ran all the mental health boards here in New Jersey for a number of years, and so my office was down there. And it's always wonderful to be back in Newark, and I love this city. And it's always great to see the wonderful work that Newark Community Health Center is doing here in Newark and throughout Essex County, especially in the area of women's health and maternal health. When I became executive officer at HHS 20 years ago, I was briefed. I spent a couple of weeks meeting with the various different divisions within HHS, and all of them were briefing me on in their particular area. And I remember meeting with the HRSA administrator. HRSA is the primary agency at HHS that handles women's health, maternal health. And he told me that Region 2, which, as Pam mentioned, is New York, New Jersey, Puerto Rico, the Virgin Islands, and 8 Indian tribes, which is my region, that it has one of the highest percentage rates in the entire country in terms of mortality, maternal mortality. And I thought that was because Puerto Rico and the Virgin Islands were in Region 2. So I thought that, they were skewing the numbers because of all we know the many challenges that Puerto Rico and the Virgin Islands have to deal with. But to my surprise, he responded, no, it's actually because of New York and New Jersey. New York and New Jersey, when I started, had one of the worst rates, percentages in the entire country in terms of women's health outcomes, and especially mortality, which I found absolutely stunning. I could not believe that two states as advanced, as sophisticated, as wealthy as New York and New Jersey would have that horrible distinction. So we started working with both states, and we've made some great progress. And a lot of that progress, actually, here in New Jersey has been in the last few years, thanks to the Murphy administration and to Tammy Murphy. We have a number of programs at the federal level, most of them, as I said earlier, under HRSA, where we have invested significant amount of dollars these last few years under this administration and under our current secretary, Javier Becerra. Title 10, which is family planning, has received significant funding. And that's to make sure that women who want to get pregnant can do so, have the access to all that they need, and those who want to avoid pregnancy can also do that with the resources that are available at the federal level. And then, of course, we've been a lead in reproductive health because we strongly believe that every woman should be in control of her own body and her own health. We also have been taking a lead in extending postpartum care, and New Jersey has, again, I go back to New Jersey, under the Murphy administration and Tammy, has been a leader in the nation in terms of postpartum care. Now, if a woman is on Medicaid, her postpartum care would end, and it depended on the state, it would end maybe a month, 2 months, 3 months after she had birth. Now we've made it possible for that coverage to be extended for 12 months. And New Jersey was one of the first states to step up and say, we will do that. We will cover women who have babies for a whole year after they've had the baby. And unfortunately, not every state in this country does that, by the way. You'll be surprised to know that not every state does that. So we're working hard to try to get other states to follow New Jersey's lead on that. Mental health, we've seen a huge challenge nationally in all areas, especially after COVID, in the area of mental health. People have, COVID did a lot of harm, and a lot of people don't realize. Of course, we know about unfortunately, the millions who died from COVID, and those who are still suffering from long-term COVID, and other issues related to COVID. But some of the things that we don't remember are the mental health issues that people have had to deal with during COVID and since COVID. And of course, women, especially women who maybe they're single parents, new mothers, they have some additional challenges. And, COVID was just so devastating. So we want to make sure that the resources are there. We have invested millions and millions, hundreds of millions of dollars into SAMHSA, which is our mental health unit, to make sure that we're providing the mental health services that women need. And by the way, a lot of this, what I've been mentioning and what I'm going to mention, a lot of it is done through our Community Health Center program, Federally Qualified Health Center program, FQHCs, which is one of the biggest programs at HHS. And I have to say, we're a huge department. We have the largest budget in the entire federal government. We are 1/4 the budget of the federal government, and most grant programs are out of HHS. But I have to say, in the 20 years I've been with HHS, the program that I have been most proud of, and the program that I enjoy the most, is the federally qualified health centers, because the work that these centers do is amazing. They provide health care, access to health care, to everyone, regardless of their ability to pay, regardless of whether they have insurance, even regardless of their legal status. If they're undocumented, unfortunately, a lot of undocumented individuals are not able to access the resources that are available, but they can go to a community health center and walk through that door and get served, and no one is going to ask, let me see your papers. So I want to thank all of the community health centers, but especially I want to thank Newark Community, because they've done such a great job here in Newark and in Essex County. And then, of course, one of the issues when we came into, when this administration came in, one of the issues that we were dealing with were equity, racial, economic equity. We saw that there were deficiencies and gaps in people communities of color, in disadvantaged communities, getting access to health care, and that should not be. In the United States, we should not, especially in 2021, 22, 23, that should not be the case. So we have invested significantly in making sure that all our programs, all our federal programs, especially those under the FQHC program, are available, accessible to everyone, regardless of their skin color, regardless of their economic situation, regardless of where they live. We also want to make sure that we have culturally competent healthcare. So, the community that has, a large, here in Newark, for example, you have a large Hispanic community, and I know Pam has a lot of Hispanic patients, and her staff, they do great work in reaching out in Spanish to her patients. So we want to make sure that our resources at the federal level get to everybody equally. That everyone has the same access to what we offer, and irrespective of their situation or their condition. And so I am happy to be here today to share that with you, because again, this is a very important issue for us at the federal level. Women's health was not a priority, unfortunately. There were times that it was a priority, there were times that it was not a priority. When we came in, when this administration came in, I keep saying when we came in, but I came in 20 years ago. I'm a career employee, but when this administration came in, unfortunately, women's health was not that big a priority, or as big as it should be. And we have taken steps under this administration to make sure that does become a priority. And I want to thank Newark Community Health Center. And I want to thank all of you, because I know many of you are leaders here in Newark in this field. I want to thank you for for also stepping up and taking a leadership role in this. And I want you to know that we at HHS are your partners. And I know, it's often said that the scariest sentence in the English language is, I'm from the federal government and I'm here to help. But actually I am from the federal government and I do want to help. So, please know that HHS is a very willing and available partner. Feel free always to reach out to us. Pam knows where to reach me. She has all my phone numbers and all my emails, and I hear from her quite often. In fact, I got an earful earlier from her and the First Lady on an issue that as soon as I get back to the office, ma'am, I have to leave because I have a meeting at 12 o'clock. And my office in New York City is across the street from the courthouse where the Trump trial is going on. So traffic is a nightmare. To get in and out of that area, Lower Manhattan, with all the security, police blocking streets, it's just a nightmare. So hopefully it's 11:10. Hopefully I'll be able to get to my office by noon. But Pam, as soon as I get to the office, I will assure you that I'm going to look into that issue that you brought up, and I'll do my best to resolve it. Thank you all very much, and enjoy this.
We're truly grateful to Mr. Gonzalez. As you can tell, a lot of our funding comes from the federal government, and so you have to have him on speed dial. And he does amazing things for us. And what the board members just realized they know is that we as the staff get the work done, but when anything happens, the federal government is calling them. So you didn't scare them off. Did he scare you off?
That's bad.
All right, thank you so much. Let's say thank you. And so we're going to move into what you came to hear. You've heard from Mr. Gonzalez, and he was supposed to be on the panel, so he gave you everything before you left. And the First Lady gave you everything that she left. So now I'm going to introduce somebody who's like a board member, because she's always helping us doing a lot of things for us, and for little and no money, and she does it joyously. I want to introduce Ms. Carissa Lawson. She's an award-winning morning anchor news. So, do you know her face? Yes. I know, I don't know. She's a news anchor for CBS News. So she'll, yes, okay. Okay, so prior to working with CBS, she worked at News 12. That's why I say you know her face, right? Yes, and she's sorely missed. She's a proud graduate from the New York University with a degree in broadcast journalism. Upon graduation from NYU, Ms. Lawson earned the James Fenimore Cooper Memorial Prize, which is presented annually to the most outstanding undergrad student of journalism. Isn't that awesome? She was also inducted into the Kappa Alpha National Honor Society in Journalism and Mass Communication. Ms. Lawson has been nominated for 2 Emmy Awards, and as a former evening news anchor for CBS affiliate, she was a part of the team who received the prestigious Edward R. Murrow Award for the Best Newscast and the coveted Service to America Award. This honors exceptional public and community service. Isn't she amazing? She also personally won the North Carolina Associate Press Award for feature reporting. While at News 12 New Jersey, she won the New York Press Club Award for breaking news and the New Jersey Society of Professional Journalists Award for the best newscast. She is also proud to receive the Outstanding Community Service community service in New Jersey. As I said, she's amazing, and she's like a board member to us where she always gives her service, and she never fails. And so without further ado, I would like to present our moderator for the rest of the day, Ms. Carissa Lewis. Can everybody hear me?
No.
How about?
Well, it's always so awkward to hear about yourself, right? It's just like, Dr. Clark, thank you so much. It's my pleasure to be here once again. I was here last year, and I'm just honored to be here. You know, one of the things that Dr. Clark and I talk about is that sometimes it feels as if we're preaching to the choir. You know, some of the free services that was discussed today by Mr. Gonzalez and First Lady, it seems as if oftentimes a lot of women don't know that this kind of these kinds of services exist for them to take advantage of. And I think that's one of the things that we really need to work on, so that more women realize that New Jersey really is trying their best to make a difference and to make up these terrible statistics that we're talking about. You know, as a journalist, I like to do a little bit of research. So I looked into health disparities. What is that? What does that mean, right? So the National Institutes of Health defines health disparities as differences in incidence, prevalence, mortality, and burden of disease and other adverse health conditions that exist among specific population groups in the United States. So when we think about the disparities in quality healthcare access for women particularly, some might say that we could be facing a crisis if we do not improve the health outcomes we see based on these stark statistics that Dr. Clark told us about earlier, and also that the First Lady talked about earlier as well. I mean, it really is just devastating to hear the kind of numbers. It's really just so shocking if you really think about what's going on in our state and across the country, quite frankly. We can all agree that it is vital that we try to reduce the biases and disparities that exist using the most powerful things that we have at our disposal, right? Education, communication, and action. What we're doing here is we're communicating. But what we need to do next, and continue to do, is the action aspect of it. Get the information out to these women who need the help so desperately. So it begins with the kind of conversation that we are about to have this morning with our distinguished panel of guests this morning. Dr. Charnae Brown, Chief Education Officer of the Mayor's Office of Comprehensive Community Education. I want you to listen. Yes, thank you so much. I want you to talk a little bit about what you do at your office and why you're here today.
Okay, so hello everyone.
You're playing with the mics. Okay.
Hello, my name is Dr. Charnae Brown. I'm the Chief Education Officer for the City of Newark. I work under Mayor Raj J. Baraka directly in his office. Basically, my responsibilities include everything from prenatal up, dealing with education initiatives from the mayor. We don't have direct supervision, but the mayor's influence, we influence policy initiatives, we monitor the systems, provide feedback and support. And so I was really thrust into this work because recently, in July 2023, the mayor he gathered a brain trust in response to the literacy scores, which also was extremely impacted by COVID. And so he created the 10-point literacy plan that was based on that group's recommendations on how to address literacy. Point 6 says get prenatal care and read to the unborn child. That work led us into kind of like discover a major, even bigger disparity in maternal health. And so we couldn't talk about quality prenatal care and not talk about maternal health. And so since that work, we've been kind of really immersed in work improving outcomes with maternal health and doing some of that work and getting that out there pushing the 10-point literacy plan, which I advise everyone to go on the mayor's website and really look at, because literacy is an important issue and very related to this. But we also did the Creative Project, which is a conference that we had in December 2023 with all the stakeholders giving wonderful trainings and support on almost any issue you can think of doing maternal health. And upcoming, we're also continuing that work. It's not something that stops, right? We continue meeting people around this issue, bringing awareness, coupling it with the importance of early literacy. And also, we are having an event coming up at the end of this May at the museum showing the viewing of Aftershock with Tanya Lewis-Lee, and continue to convene the stakeholders so we can do policy that's relevant to Newark, right, and relevant to New Jersey. So this is how we came in. So I'm not an MD, but I am a doctor of education, so this is how we got into the book. Thank you.
Thank you so much. Our next panelist, Rhea Rodney, the director of Nurture NJ.
Good morning, everyone. It's so lovely to join you. Thank you for having me. My name is Rhea Rodney. I'm director of Nurture NJ. I sit in the office of our lovely First Lady, Tammy Murphy. I'm responsible for executing our strategic plan and making New Jersey the safest and most equitable place to have your baby and raise a family. Prior to coming to Nurture NJ, I am a registered nurse by training. So I've worked in public health, community health. If you go to the hospital and have your baby, I'm the person who takes care of you afterwards. I've worked in the special baby nursery or the NICU. And I come to this work from not just the healthcare perspective, but seeing your friends go into the hospital to have their baby, and just events that could have been avoided. So it becomes very personal. It's not just statistics that we hear, it's the stories of close friends, close relatives. How can I get involved? How can I make a difference? I'm also a doula, so as we talked a lot, doulas are trying out to change these narratives, right? So we are hearing things like women of color are 7 times more likely to have near-death events, or 7 times more likely to die, not when they have a doula. Not when there is education on board, when there's prevention on board, when there's advocacy. So I'm really here to connect all the dots. Everyone in this room is here because they're a champion for women's health, for prenatal care, for children's health, and we're working together to break down these silos. As mentioned earlier, there's been 66 pieces of legislation passed in New Jersey to move public health initiatives forward for women and children. So let's work together to have these discussions when we leave here, to continue them in our communities.
Wonderful, wonderful. Thank you so much. Joining us as well this morning is Omar Bey, who is on the board of NCHC.
Thank you very much. Good morning, everyone. To be honest with you, Dr. Clark stuck me out here, so let me just tell you from a board perspective. NCHC was so proud of what Dr. Clark and her team, as well as everyone who works at NCHC, is able to do for Essex County. And this forum has been going on for several years, and each year it gets bigger and bigger and bigger and better. And I think that's just a credit to Dr. Clark and her, what she's able to do for Essex County and women's health. It's so important now. From a board's perspective, understand that I'm a physician. I've been practicing for too many years. But the thing is that we truly understand how important healthcare is for those who are underserved. And you think about it in many ways. Number one, what is good health? Do you know what good health is? That's number one. Number two is, how do you achieve good health? All right. Number three would be, once you achieve that good health, how do you maintain that good health? And those are some of the things that are so important to NCHC. We at the board have talked to Dr. Clark about not only giving the services, having the services available, but let's start talking about education. the actual educating the patient about their problem, and then you're really doing something great there. So what we're talking about is that you can give a person a fish and they will have a great meal. But if you show them how to fish, then you change lives. So that's what we're trying to do at NCHC. We're trying to educate the population as to what's wrong so that they can be an integral partner in taking care of themselves. For instance, there are many close ties that we have to the hospitals throughout the area. And it's important because then you're starting to talk about, the specialties. You're starting to talk about cardiology and pulmonary and GI and infectious disease, which we don't have in the health centers themselves, but they are an integral part of people being healthy, so you have to tie those in. And when you tie those in, then you can educate the patient about why they should continue to see this specialist. It's very, very important. Number two is that in education and educating these patients, for instance, let me give you an idea of the partnership that's taking place at this particular point. There's a corporation called OB Healthy, and that particular corporation, they host a webinar every second Saturday at 1 o'clock. And you can go on that webinar, and we encourage our patients to go on that webinar, and they can actually type in medical questions, and doctors from this area, doctors, and doctors that are the color of the patients that you're looking at somebody who's your color, and you're saying, okay, let me ask this question and get a perspective from a black physician's perspective on this disease. It means so much. So those are some of the things. When you talk about medicine and doing better, it's all about, to me, it's all about educating the patient. Thank you.
Dr. Clark, that was very smart of you to get him up here last minute like that. I'm very impressed. Okay. And we are just honored to have all three of our panelists here this morning. Of course, I have several questions, and you all don't have to answer. You can each, take your turn. If you don't wish to answer, we'll move on to the next one. My first question for you this morning is, how do existing healthcare policies contribute to the disparities in women's health outcomes, particularly among marginalized communities?
I don't mind taking a shot at that. I look at it as it's not just a policy. So I look at how the disparities exist in a larger, broader context. And I think that it's important for us to look at that broader context because these disparities are maybe part of community problems that impact and compound issues that lead to other disparities. What do I mean by that? We don't like to really talk about it as often, but if we're in certain communities, we're dealing with air quality, we're dealing with lead, we're dealing with other things that impact people's health. Newark was considered to be a food desert at one particular time where the access to healthy foods was not accessible, right? And not affordable, right? We just recently, maybe within the last, I'm not sure 5 or 4 years, got a new shop, right, and a Whole Foods added to our area. So issues like that also all impacted, and we don't really say racism enough, but the broader context all contribute to the wealth gap, the lack of access to quality health care, food deserts. And so I like to look at it as not just policy, but it's the broader context, redlining and housing insecurities and violence, and all of those things impact health disparities. And so we like to look at it not necessarily always from a deficit model, that the patient is coming with a lack and adding to those deficiencies. We also like to look at the system in the totality, that the systems may be inherently racist, right, and have barriers that need to be unpacked and addressed. So I just wanted to add that to not just specific policy, but a broader context that causes and acts to and compound disparities.
where you go for care, where you deliver your baby? Does my provider look like me? Do they speak my language? Is there that level of cultural congruence? Do they understand my diet, my nutritional needs? And looking at how do I navigate finding a provider that I can really feel heard and feel connected with. Before we would rely on word of mouth, right? Like, oh, I went to this doctor, they're great, you should check them out. And now we're in such a digital age that you can use the technology to more navigate, right? Read reviews, those types of things. A few things that we're doing in New Jersey specifically, when we look at connecting NJ, you can put in your zip code and look for things like food pantries, diaper resources, healthcare providers, daycare, which in the past we were really relying on our networks and perhaps they didn't know, or perhaps these services weren't available. And then other things that we think about, right? Like, again, using that digital era to really learn more what's out there. We now have healthcare hospital report card. We have a New Jersey hospital report card where you can compare hospital, like do the side-by-side, look at what's offered, what's best for you. And I think in the past, you know, like when we talk about healthcare policy, you would think like, okay, it's this topic, this is how it is. But we're really communicating across the state to really change these conversations and just expand the knowledge, expand access. When we talk about policy, even in a hospital setting, like let's say I'm going in to have a baby. In the past, the hospital sets how many visitors can you have, who can be in the room, who can come in and out. And we now have a doula access bill saying like by law, your doula has the right to be there. So we're shifting these conversations to make sure that people have access to the resources that they really need.
So they needed a law to say that a doula could be in the, that's incredible. That's incredible. Would you like to tell? No? Okay, all right. Yes, they did, absolutely. All right, so my next question this morning is, what legislative measures can be enacted to address these systemic barriers faced by African American and Latina women in accessing prenatal and postpartum care?
I'll start. So, our governor has signed over 60 pieces of legislation specifically for maternal child health care. And one of them is towards implicit bias training. We know that systemic racism exists. We know that it's built into our systems of healthcare, education, the environment, everything. So we actually do have a law saying, like, you need to take this training. You need to take implicit, explicit bias training. And this is a way to hold our providers accountable for their continuing education. And I tell folks, you know, when you're going to your appointments, it's okay to ask, like, oh, have you completed your implicit bias training? Because now this is something that we're doing in New Jersey. We acknowledge that it's an issue and we want to address it. So that's a good starting place.
I just want to add to that. I think that's extremely important because it is not just, because we talked about really having people who look like you, right, serve you. And I think that that's important. But I think what's inherent in that implicit bias is understanding that there might be just biases and elitism and things like that that really add to trauma. When we look at the trauma-informed care, there's stress. There's a research, Vicki Mays talks about the impact of microaggressions and discrimination compounded and added up, its impact on health outcomes and what it actually does to the brain, right? What it does to the pressure, right? And so all of these things are important if we're going to thrive in any health outcome. I mean, when we look at pregnancy, that's major, right? But in the context where you're trying to survive, overcome, and thrive, you actually need to have your health and your wellness and your mental health in a good state. When we add to compounded discrimination, it impacts the health outcomes of African Americans. And I think that that's also something that we don't talk enough about. Probably also the Latino population just probably need more research. Just the stress of trying to thrive, maybe undocumented, going through systems that add to the trauma. And really getting doctors and nurses and stuff like that to, when they develop cultural competency, have a value and respect for the patient as they're advocating for for themselves, right? Because as a woman, I'm a new mom, right? Even as I was navigating certain situations, sometimes doctors aren't as open and welcome to my suggestions, recommendations, feedback, or questions. They feel offended. And so while we have a doula to navigate us through birth, how do we get marginalized people to navigate through systems where they don't really feel welcome? And when they are in the spirit of advocacy, they're considered difficult, or not respectful, or uneducated, because maybe even how we communicate our advocacy is not also welcome. And so I think that that's also, I would like to see embedded in that legislation, so we can make sure that we all bring some type of bias to our work.
I think that bias is across the board.
Yes.
The thing is that as a physician, I come in contact with it every day where other doctors don't understand the culture. For instance, if I'm seeing a black patient in my office, I understand that patient. I know what they eat, I know where they live, I know the culture, I know what, the taboos, I know you don't sit your pocketbook on the floor. I know those little things, I just understand that person. If a nice little Jewish lady comes in and sits in my, I don't know her. I know I can treat her hypertension, her diabetes, or heart disease, but I don't know her like culturally. Like I know someone who's black that sits down, or Spanish who sits down in front of me. I understand it. You understand also many physicians come from other countries. How they grew up, who they were, whether they came from a rich family or a poor family, all of that impacts on subconsciously how they're going to relate to that patient. You understand? And it is true, there is so many biases. But from a patient perspective, you should understand that we are, how should I say it, our surroundings dictate what we do, how we interact, all of that. So if you're in front of a physician, number one, you're holding high. You shouldn't be holding them high. They're equal to everybody else. When they speak and when they say something, then everything is 100%. He's right, I'm wrong. That's not true. Number one. Number two is that if the doctor or if anybody in healthcare is not taking care of your needs, then you should have no question to change your physician or seek other advice or get another opinion. In my practice, I think a second opinion is the most valuable thing that can occur for me and that patient. Because I don't think I'm the last word. We're all different. I don't care if everyone in this room had diabetes. Guess what? Each one of the patients are going to have something specific for them or different from the next person, and the treatment's going to be different. So that's just the thing. Have that, and that's where we go with education. Have that determination and that foundation and say, if I take my car to a mechanic and he doesn't do a good job, guess what? I'm not going back. But if I go to a doctor and he doesn't do a good job, then I keep going back and expecting him to do better next time. No, it doesn't work like that. This body is the most important thing in you own. And if you can't take care of that, then guess what? There's a major problem. So it comes down to the person. And that person has to, has to respect themselves enough to say, I'm going to find the right physician, I'm going to find the right hospital, I'm going to find the right, medical care for me. Now, not saying that may be easy or whatever, but that's where the education comes about. Each and every one of us should be educated to understand that this is me, this is the most important thing that I own, and I want to make sure that the person who is giving me advice about it is giving me the best advice that they can. Not saying that they know everything, but at least they give you the best advice that they can give.
Yes, absolutely. And this question is here, based on some of what you guys have been talking about, and what specifically some of the things you were talking about, what we hear in our own lives, and you mentioned this in the beginning when you introduced yourself, is sort of like this dismissiveness that when a lot of minorities go to the doctor and they make a complaint, and there's a dismissive attitude about my pain, whatever it is, how can we address that issue? That is an issue that, like you talked about, friends that we know, stories that we've heard. This is not a regular statistic that we're hearing. These are people that we know are experiencing this. How do we address it? Okay, go ahead.
Let me just talk about, and you brought it up, early sensitivity training. That's something that local organizations have to undergo at this particular point. The problem is that it's something you sit down and you look at and you answer some questions and that's all. And did it really change you? No, it didn't change you. It made you aware that it's occurring here. What, me? Unsensitive? Not me, That's just human nature to think that way. I think that we have to, and the fact that you may go to a doctor, and studies have shown that patients go to a doctor and one both may have chest pain, one gets a medication that may help with esophageal reflux or GERD or heartburn. And another one gets a cardiac catheterization to rule out a myocardial infarction. Well, that is true. One gets ruled out a heart attack, and the other one gets medication for heartburn. But that happens all the time, and that is that implicit bias. Now, how do you change that? It's a cultural change. It's over time it's going to change. But I think the number one of the primary ways to get it started is things like organizations and companies like NCHC, because that patient knows when they walk in the door, they're going to be treated, everyone's treated the same. I don't care what color you are, how rich you are, how poor you are, everyone's treated the same, and everyone gets excellent care. To start it that way, and if patients get used to being treated or getting medical care delivered that way, then when they are not there, they're going to expect the same thing. But you have to start somewhere.
Oh, I just wanted to add, I think that's awesome what you're saying. And one of the things that Mayor J. Baraka does is really use collective impact, right, to address every issue. Like there's nothing, I see the director at Alsbrook in the audience, and she's also with the mayor's office. Hi, director, she's over the health department. One of the things that they pretty much do is convene for collective impact. For instance, when we did the Cradle Project conference, and even with the aftershock, one thing we're doing is inviting all stakeholders, right? And the reason why I said that, do we have the head of the OBGYN there? Do we have the CEOs there? Are we watching aftershock to create empathy, right? To humanize the person who's no longer there, can't even advocate for themselves. And I want to shout out to my students who passed, who were very young. I want to just shout out Letitia Faines. I want to shout out Novia Brooks. These are real students who maybe they had children maybe in their 20s, right? And they did not survive, right? And so when we are organizing and convening, we want all people at the table. And the reason why is to put the burden, right, on the patient, right, to carry the load. It's heavy. And we're already, interacting with this implicit bias already is impacting my health outcomes. Because my pressure is elevated, that doesn't help a pregnant mom. So if we educate everyone and get everyone committed to this issue, and women, this is our issue. These are the issues that should get forefront, on all levels, federal, state, and local, and not let everybody else decide what's because this is our survival. Everybody has to get to learn it, and we need leaders to commit publicly, right, that this is a priority, right? That will make a mother's all over feel better to know that this is a priority. I don't have to go to this clinic or whatever and advocate. They stood right around this issue. They got some policies. They're doing their own work. So that relieves me. I feel safe. Right, and so that type of army building and collective support around this pertinent issue is the type of support we really need. And Mayor Rashid is really making this the type of issue that gets that type of support, using that platform to bring everybody together. So,
awesome. I would just like to add that I tell people, don't let anyone silence your voice. Don't be afraid to talk about it, to share your experiences, be them positive or negative, not just in your community, but on a public platform. I think there's power in sharing these stories. And what happens, let's say you had a negative interaction, you might leave just like, what just happened? But then if you go online and read 100 people are saying the same thing, it's going to raise some flags. I think it's a way to hold some accountability. So I always encourage people, write your elected officials, write your hospital administrators, have those conversations, because we want to highlight folks who are doing it and doing it well, and folks who might just need a little bit more guidance. We're okay having those conversations on shifting the culture so it's more inclusive.
So in what ways can federal and state governments collaborate with healthcare providers and community organizations to improve mental health care access for minority women? Because that's huge right now.
Mental health care. That's a big one. You know, the thing of it is that the availability for mental health care is not what it used to be. I can remember back in the day when, many years ago, when mental health care and the ability to be institutionalized, if you need that to stabilize yourself so you can go back out in the community and be a viable person, that option is there across the board. But and I can't remember exactly when, but at some point in time, if that option was taken away, and hospitals, the patients in the hospitals were released, and we had a homeless problem and a mental illness problem, and that continues to be today in many states and in many cities. How do we correct that? Number one, I think our legislators have to, number one, recognize that it's a real problem. Number two, allocate money so that organizations that may be able to help can. And on a larger scale, institutions for those patients that really need, more physician care, more hospital care, or maybe to be admitted short term so they can really be stabilized. That has to be available, which I don't think is truly available in this particular way, at the level that it's needed. So those are some of the things that I think just at the basic level, without, you can have the laws on the book, books on the laws on books and stuff like that, but if there are so many laws on the books that there is no money allocated to it, it doesn't mean anything. So what we need is legislators that will take this seriously and say, mental illness is a real big problem. Let's allocate some money and let's get the institutions that truly can help these people, get the programs going. Because without money, we can talk all day long. Without money, it's not going to happen.
My input would be a little brief. I think COVID did a lot culturally on how we look at mental health, and I think it's actually going to be helpful, right? I don't think COVID room itself was helpful towards our mental health, but to be able to say out loud, I need a therapist. I know that culturally that was a big shift for like my churches. Just people were able to say. I want to say we do a lot of work with young people, and this next generation is going to help with that shift, because the conversations, we did an equity conference, an educational equity conference last year, and their biggest emphasis came out of it was to focus on mental health. So they don't look at mental health as, let's say, just an illness, just isolated to some people, but just looking at it as we all have to manage our mental health, just like we all have to manage our physical health. And I think that conversation is also going to be helpful when it comes to women, when it comes to women's issues, specifically pregnancy, because a lot of things that people could have been struggling with postpartum, we blame culture, we blame the person, we did a lot of blaming, and we did not support. And I think that what organizations like myself will be having doing is just becoming more mental health responsible. And so when we have events, have resources at the events. Just like really champion mental health is something we all have to invest in, manage, monitor, and be aware of resources. Our office actually even took what they called mental health aid training, where you don't do, I'm not doing CPR or anything like that with somebody's mental health, but just seeing some signs and knowing how to respond and even give a number. And so I just think that that type of stuff, as we are all championing legislation, embedding things like that to make mental health accessible and make us aware, and to say it's okay. It's okay. And being a new mom, I have a 1-year-old. I have a new, can I just clap it up for every mother in the room? Good job. I am still managing to see about my postpartum, right, because that's all new. But just really, when I look at the level of responsibility a woman has, this 24-hour watch thing that goes on when you have a child, 24 hours, 7 days a week. Even if it's somebody that's in somebody else's care, that watch is still going on. The amount of anxiety, the amount of pressure, the amount of stress that comes from mothering, I think we need to have responsible legislation like direct payment, more extended maternal health leave time, like really things, because what we also have to manage is, and I don't have the exact figures and I apologize, but women make up a large part of the workforce, right? But we are the ones who have children. I got this from Nicole Hannah-Jones when she said 99% of a black woman's dollar goes to the community. So I'm right, it's only 1 cent left, right? All right, so I'm saying, how are we supporting this mom and definitely parents, but how are we supporting this mom as she goes through this transition? Because part of the stress in not surviving could be because I'm still managing the same level of responsibility that I was supposed to do when I wasn't pregnant, right? And now I have to manage it postpartum. And I was actually shocked, and this is just a mom experience, we can throw it out there. I was actually shocked, and I might be oversharing, but did have a C-section, right? I was actually shocked at the amount of work I still had to do while healing, right? This surgery, right? And so it's just like that type of stuff, like how can we support? And I think this has nothing to do with your social economic status. Like while we're extending WIC and extending Medicare, those things are wonderful. Can we do guaranteed income? Can we do direct payments to mothers for a certain experience, just so they can heal and pay the bill, right? And feed and keep the lights on, right? I mean, come on. I'm going to add this one last thing. That means, women, that we have to be at the forefront of that conversation. One thing I like about decide what the policy is, right? We convene and listen. Women have to bring that lived experience to the table. So you know what will really help me, right, legislators? Come with that experience that only you have and get support and not think of it as a handout, because 99% of your dollar already went to everything that you would get for support. So I just wanted to say that.
Talk about mental health. First of all, there is no health without mental health. Let's start there. There is no health without mental health. So this needs to be at the forefront of our conversation. When First Lady Tammy Murphy started this Nurture NJ initiative, she went on listening tours and just met with folks throughout the state, doctors, midwives, nurses, doulas, mamas, daycare workers, everyone, right? And folks are like, this is what I need. And we're talking about like how can we collectively bring it together. I want to just mention Family Connects New Jersey. And this is a home visitation program that I think is going to be a game changer for our community. Because if you have had a baby, you know that the follow-up time with your OB, with your baby, you know, you get in a few days very quickly to see the pediatrician. But for you yourself, it could be anywhere from 6 to 8 weeks. And you have to take a bus, a train, a taxi, how are you going to get there? Do they have hours? What am I not at work, right? But now we have a registered nurse coming to your home within 2 weeks of delivery to check on mom and the baby. And I'll just say, Black women, we typically don't say like, I'm depressed or I need help. But it might be, how are you eating? How are you sleeping? Do you have help? How are things going at home? Do you have help, right? And asking questions in such a way to get the answers and get families connected with the services. That is the whole entire goal. So you're not taking multiple modes of transportation. You're not waiting weeks and months. Like you're getting the access to care now. And I cannot emphasize enough. This program is live and ready right here. So we need to utilize these services. And when you say like, I just don't feel like myself, you know, that is letting the nurse know, let me connect you with somebody. So you're not spending hours online trying to find a therapist. They're going to give you a name right there in the comfort of your own home.
Let me just say one more thing. I think you hit it right on the head there. Culture. Black and Hispanic. We as culture don't want to admit that come forward and say, I need psychological or I need mental health.
It shows like a weakness, you know.
It shows that similar. And the thing is that most of the time, I know when I talk to Black patients, they're like, the first thing they will say is, I'm crazy. But we're not talking about crazy. We're talking about mental health in the sense that just someone to talk to, someone to get you through the rough parts. Not that when you have schizophrenia or any of the medical problems that we arise. We're talking about just psychological problems. And the postpartum, believe it or not, postpartum depression is a real entity. And it's something that a lot of females go through and have to deal with it on their own as they're dealing with taking care of a new baby. And it's something that can be very dangerous. So that program that you're talking about is amazing. And I just applaud the First Lady for starting that and pushing that forward.
And anecdotally, one of the things I'm finding within communities is that there aren't enough mental health care providers. They're overwhelmed now, you know, and they just, it's like you're in a crisis and they're like, oh, we have an appointment for you, 3 months from now. It's like, I need help right now. And so that's an issue that I'm finding a lot with people as well. All right, so how can data-driven policymaking be utilized to identify and address gaps in healthcare services for underserved women populations?
Just from an education perspective, always unpacking the data, right? One thing we did with the 10-point literacy plan is say, you know, how do we unpack the data? Like I think we hear often Black women are 7 times more likely, Hispanic something that could be solved. Most people are talking about it being preventable. So just being data responsive and not being afraid to really look at data and unpack it. And then how do we create policies that will actually support that and just make whatever those barriers were, whatever was preventable, not happening. And I think that while Tim Murphy is doing certain things on the state level, I think it's really important to engage our local providers, our local government, and say, what is our data saying specifically? Because unpacking New Jersey's data might not necessarily give me a good enough picture of what is happening specifically in Newark or at the local hospital. So and then having an inclusiveness around looking at this data. I found that the best practices that we have at the mayor's office is bringing the community feedback. That is invaluable, and I think that being something, in my former life, I was a principal, and sometimes, as the leader, you create a lot of policy, you think it's going to go well, and I found that my most meaningful change that happened in my school building came when I listened to parents and did what they said. Now, I'm the one who got the training, I'm the one who went to school, but they knew what they want. And so including that type of community support and feedback and input on all levels, so we can have kind of like boots on the ground, right? I hate to say boots on the ground because what else is up? The hospitals and stuff like that on the ground. And then making sure that our hospitals are getting support for quality care. Like, is my local hospital suffering with funding, right? In my byproduct, right? So how can I look at the health of my hospital system? And how can I support my local hospital? Because that might be the choice when and we're not waiting for the baby to get involved in that work, right? Because we create babies, right? So that can be any time, right? So just like how do I get involved in that and get involved in looking at the data and creating policies for that?
So I'll add, nationally, we really haven't done a good job at collecting data. Like, you hear these statistics, and then it's like, well, what does that mean for me, for my community, for my zip code? Like, how do these national statistics translate to my life? And I think one thing that was talked about earlier is our new Maternal Innovation Authority, or MIA for short. It's coming to the state of New Jersey. That's going to help us in our data collection and how we translate that into policy. So I'm really excited about that. And then going back to just looking up data in terms of policy, we do have like patient-facing data, your hospital statistics, those types of things. When you go and meet with your healthcare providers, when you go on tours, just ask questions like, well, I saw, you might be on a tour, and I saw online that the C-section rate is this. Like, can you just tell me a little bit more? And there are people there to answer your questions, and that might impact how you make a decision on where you get your care.
That's good. Looking at this problem, or looking at the question from NCHC point of view, and we're talking about nationally as well as locally, and the numbers that you're talking about. When you take these numbers and you look at them, what they do in the FQHCs or the federally qualified health centers is each month we evaluate many different aspects of medicine. Did the children get their shots? How many children got their vaccinations? colonoscopies. Just many aspects. There are about 19 to 20 of them. And each month we have to go through and see exactly how we're doing compared to the national average, compared to what the federal government guidelines are for those particular for them. And over the time we do the research. The numbers are there for each FQHC, so you can take it locally or you can take it nationally and see how things are compared around the country as far as how that, and just to back up, that is how the federal government actually understands how your health center is doing, because all of these parameters are being compared by other FQHCs throughout the country, and that So the research is there, the numbers are there, and each NCHC has those numbers, and those numbers are easy to get. So at a federal level, they evaluate that. Now, whether it trickles down to a local level, I know for us at the Community Health Center, it's very important to us, these numbers. And we set a higher number or a stronger number to get to than the federal number for our patients when we evaluate whether our center is meeting the standards that it should from a federal level.
What strategies can be implemented to enhance health literacy among women, particularly those with limited education and language barriers?
Well, I was just talking about community partners, and I just want to thank you guys because this room, they're really doing that work. So let's shout out to everybody that's around tabling and doing it. That work is happening, making people aware of just empowering people. That's how I look at it. Like, how do you empower people with information? That's actually happening. And so I know that from the Cradle Project, we created a Cradle Project coalition. And that is about keeping each other aware of initiatives that's happening, not working in silos, right? And then how do we get people in the room collectively, right, for each event to kind of bring awareness. And then institutions letting us get access to the people that they service every day with information. And so I think that that's one way. The 10-point literacy plan was one way to kind of just help people to understand that there are studies that actually show that reading to the unborn child creates more brain activity, right? And they have more memory. They create memory while in the womb of speech material, right? And so literacy doesn't start when you're just being born, just simply reading a book or two to the baby. You're developing and broadening the likeliness that the child may memory and learn words into their lexicon soon. And so I think that type of stuff, that's and you don't have to be, the mother doesn't have to be the only one to read the book, right? It can be, and then there's so much other stuff that reading does. It reduces stress, it increases sleep. Hey, come on, all that stuff a mother needs. And so I think just giving the information and learning, there's so much learning and fruit, right? I don't have to be a genius, I don't have to have a doctorate. I'm already doing it, let me just be more intentional. So just the community partners, this is what we really need you to just keep doing the work that you're doing and keep challenging institutions to keep passing that information. I know you're doing grassroots work, you always leave, and I'm laughing at my team, you always leave feeling like, oh, I want people in the room, I want that. And what you're really doing is you're forming people who are going to reproduce the work. And so just really keep doing what you're doing, be more responsive. We have an event, the Young Stars, coming up in August, like it's wraparound services, like our director who's in the room, she has units to come out there and help with immunizations and things like that. And making it accessible people are here. Let's bring the information and services here. Let's not reproduce it and just keep getting that work out. And then making sure that the clinics and the hospitals also have a literacy that they're developing simultaneously.
Oh, well, don't give me a mic. As far as culture, and I think that literature, when we spoke about this, literature should be culturally person. You know, it's very important that Spanish today should be Spanish. But let me give you an example. And I can only speak from what I experienced with FEHC and NCHC. We have, seven sites. It's important that now in Ferry Street, which is the Portuguese area, that there are some people there. There are people there that the literature that we put out, they understand that people are caring for that culture. When you're in East Orange, 444, basically that's a big Haitian community. We have to have people there that speak that language. That's a 721. That's a big Spanish, area. So it's all very important in cities to step back and look at your communities and understanding communities and the health care that's necessary for those people in their community. We're doing so much more as far as helping the patients and helping the people. If you just step back and understand the communities.
How can public-private partnerships be leveraged to address food and housing insecurity as key determinants of women's health?
Goes back to what I just said, it's a kind of overlapping. When we have events and things like that, having those services in the room, making sure that, yes, it's an event about one thing, but do we have mental health resources? Do we have the mobile unit for medical support? Just really using every event to make sure that we are collectively being culturally responsive and having that information on hand. One of the things for reading those stories, you could be there to get books, right, to add to your 500 book library, because that increases the probability that you will go further in education. But you didn't know you were going to go to a table and you can get rental assistance. That's what I'm talking about. So the child is elevated, but mom and dad can go get support. And so that is, since we have access to these agencies and departments, invite them to everything, because you never know who's in the room that will need that type of support. So that's just one suggestion on how cross-sectionally we can actually, sectorally we can actually get this addressed.
Yeah, and I'll continue. I think it all starts with the network. To just piggyback off of that, it's all about the network. It's all about making those connections. When the First Lady has the family festivals, I think of it as like a cross between a block party, a health fair, like job resources. But do we have someone from housing? Do we have someone from food insecurity? Can someone get you signed up for WIC and SNAP right there in real time? Can you talk to someone? Do you know who your community liaison is? And then when we talk about like these private partnerships, just continuing to invite folks from your job, from your community, from your churches, from your organizations, bringing all these different people, all these different sectors who would not normally interface into the same room, and just having access to them all in real time. Because I might not follow up with you, right? I might not have the resources to send out these different communications, but if I can do it right now, if I don't have to take a trip, if I don't have to make an appointment, it'll get done. So that's like how we continue the work.
So what legislative frameworks are needed to ensure equitable access to child care support, enabling women to prioritize self-care and preventive measures? And I'm just going to preface this before you guys answer, talking about self-care. Something I read last night was about how a lot of women pride themselves in being selfless. And, and the thing is that, but people our loved ones need us. So we have to make ourselves important and take care of ourselves. So anyway, I just wanted to say that.
year. And I think people don't realize that's a huge deal, because in other states you have a very small window of weeks, and we're talking about you can still get postpartum follow-up for up to 1 year. Another part of that, we have a lot of work to do. We're trending in the right direction, but we're not there yet. Making daycare accessible, making more daycares affordable, making sure folks can get their kids in and they can go to work and feel safe. That's continuing that conversation. I think also when we talk about like that connection of work, daycare, it's that job security, the time when you're away from work, making sure that you have the support that you need, that when you do transition back to work, everything's in order. So there's a lot of work that we still need to do in that area.
Okay. And one more thing.
Sure, go right ahead.
Just paying the child care labor force more, right? Making it a job that we respect, because that's also filled with majority women, and they're not getting paid. So just really, I know there's a lot of onus on the parent to pay to child care, but just getting some support from like government and things like that to also help support and increase the amount of money that they're making, because we're asking and want better standards and quality from that workforce, labor force, but we're not investing in it financially. So I will also put that on the table, that will help the ecosystem to make sure everybody goes to work and everybody's comfortable.
Dr. Bay, would you like to address that?
Yeah, you know, the thing of it is that, and you talk about selflessness, and you're right about that. I hear it in patients all the time, where they will, you know, put everything towards their children, and, you know, just sort of neglect themselves. Right. You got to understand, and I always say to my patients, if you're on an airplane, the first thing they say is, you know, if the masks come down, what do? You put yours on first. Right. Because if you don't put yours on, guess what? You can't take care of the person inside of you. And the same concept of taking care of yourself. You have to, if you want that child to really be nurtured and taken care of appropriately, then you must take care of yourself. Even with breastfeeding and all of that, you have to take care of yourself in order for that child to be healthy. And it's very, very important. I agree.
Absolutely. All right, our final question today now is, how can political leaders and policymakers promote a holistic approach to women's health that considers not only medical care, but also social, economic, and environmental factors as well? Who would like to tackle that question first? Dr. Bay, go ahead.
You know, I think of it as a holistic sort of problem. And when we talk about, you know, someone doing better, and just like you, as someone had stated earlier, you know, there's no health care without mental care. But the problem is vast. That's the number one we should realize. The problem is vast, and it has multiple tentacles that have to be taken care of at the same time to get a positive result. So if it's financial, or if it's where I live, or if it's I need, you know, transportation, or if it's, you know, someone has said a food desert, or if it's medical care, all of those things must be taken care of, or at least attended to. We may not solve them, but all of them have to be attended to at the same time. That's the only way that people can really feel confident enough to move forward. And I think legislatively, we have to look at it in a broad spectrum, as opposed to, okay, I'm just going to give them health care and they're going to do well. It just doesn't work like that. We are a society that, unfortunately, for many years and many years went through slavery. All right, and if you step back on the I should say the people that we're trying to help, they're of African descent, and to say that past history didn't affect us where we are at this particular point, many of us are still in mental slavery. And if you really look at it, we have to give education, we have to give support, we have to give, you know, nurture it. There's so many ways that you have to, so many things you have to change to get a true positive
change in the culture and way we look at ourselves as people of African descent to move forward. And that's why I stated it's so many tentacles that have to be taken care of. If we could just start understanding, step back and realize what we really have to do as opposed to putting Band-Aids on, I think we could move forward. But it's going to take a lot, and it's going to take a lot of soul searching and understanding of the people that you're trying to help to get them to move forward.
Ms. Rodney?
Yes, thank you. Just to echo those thoughts, I think that if we were to shift our thinking from addressing the individual to addressing systems, we're starting to do that, and we're starting with those conversations, but making transportation accessible to get to your appointments, talking about our incomes, talking about daycare. When you shift the burden from the individual, like, are you going to your appointments, and now it's, have we created an environment that makes those things accessible, that makes them easy to do? When we take that burden off, it will help the mental health, and it will help the whole ecosystem, but it starts by really examining our systems. When we talk about policy and legislation and those types of things, again, like, not just saying, okay, we have more healthcare providers, but how do we actually access them, right? So I think we're moving in those, even like with our labor board, our labor force, like, are we protecting your job? So like when you come back from maternity leave, you feel like you can transition easily, right? For small business owners, for people who are just in smaller organizations. So I think as we continue to move forward in this work, we're gonna focus on addressing all these different systems and all these different authorities that have historically created barriers to shifting, to making access to care more, easier access to care. Thank you.
Dr. Brown, looks like you're going to have the final word.
I would just encourage people to invite people to the table with different perspectives, because it helps your blind spot, and just use a systems approach and an access approach. Social workers use the system approach, and I think we all could use it to benefit our work. Like, how is it impacting a person's lived experience? What barriers are there? Like, what inherent issues or challenges in these systems do I have to address? Just looking at all of that, and no one thing is going to be a panacea, right? Like, with the 66 pieces of legislation, we know that some of the other additional legislation came from blind spots in the acts that were already created, which is good, right? And so as we're living this stuff out, inviting people to the table, I really want to encourage women to be at the forefront of making this issue relevant and giving people access to the resources you need in order to make your life livable, even if it's living wages, even if it's lower cost of living in New Jersey, because it's just so expensive to live that you are going to make decisions on whether or not you're going to pay your mortgage or get a bigger grocery cart, right? I mean, those are everyday decisions. And then you have to get to work every day and park, right? And so, like, I think that these things aren't small. You have to look at it holistically. And so just when we are creating our coalitions, inviting people from different perspectives at the table to help us get better at our decision making.
Well, thank you very much. I think everyone will agree that our panelists deserve a great big round of applause. A lot of very good, vital information that we can take from here and get into the hands of the women who need it. Thank you all so much. Oh, wait.
Thank you so much. Thank you. Awesome. Well, you know, my staff know I don't need a microphone. Awesome. Thank you all so much. Thank you. So remember, today is all about mindfulness, your passport to health and happiness. So the question is, have you gotten your passport? Based upon what you heard the people on the stage said, have you gotten your passport? This is your health passport. Now remember, after you get your passport, what you have to do, you gotta travel. So we expect you to travel and have it stamped. And what we're gonna stamp in it? Good health and wellness, right? Mental health and wellness. So do remember what this is about today, and this was awesome what we heard from the panel. I hope you all learned something and you're gonna practice it, right? Stamp it in your passport. And so please remember that this session, it ends now, but you're gonna have a wonderful lunch. It's gonna be healthy lunch, right? So you could stamp that in your passport. Please remember the restrooms are to the back. And then after your lunch, we're going to resume in the afternoon. I just want to say also thank you to Senator Cory Booker's office who is here. Bianca's here, right? And we have Kathleen from CEO of Eliza Mohammed, another FQHC. All right, so we're going to take a break. Remember, the plane just landed, all right? You just got your passport based upon what everybody here on the panel just told you. Start to look at the scenery, go sightsee because you're in a new country. And after you're finished, you're gonna come back and have the second session with the physicians, and then you're gonna stamp your passport. So please take a break, all right? And keep enjoying. Thank you very much. Welcome again to the second half of our 8th annual Women's Health Symposium. Please remember, today is about mindfulness, your passport to health and happiness. And I hope you're all getting a mental health break today, right? Right? Right. Are you all relaxed? Yes? Awesome, 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 awesome. Now, as you know, the first half of the program, we talk about policies and procedures and what is the government or your elected officials is doing for you. But today, the second half, we go straight to the physician. Straight to the physician, and we ask the physicians questions about what can we do to help ourselves. All right, so we're going to start the second half. And the second half is slightly different than the first half. You're going to hear from an amazing physician. And this session is held by no other than our Chief Medical Officer, Dr. Amadi, amazing physician herself. And so, without further ado, I want to introduce the Chief Medical Officer of Newark Community Health Centers, who's going to moderate the second half and introduce the people.
Good afternoon, everyone, and welcome to our 8th annual Women's Symposium. This is my first time attending the symposium. I must tell you that I'm highly impressed in being here. I've worked at NCHC for 4 months right now, and I can tell you that it's an amazing place to work. You know, at NCHC, we don't only see the patients, we take care of the whole community. And this is done by our whole team, starting from our President CEO, Dr. Pamela Clark, our Chief Operating Officer, Dr. Shao, our Chief Financial Officer, Mr. Gonzalez, and also our DO and Director of Nursing and her amazing nurse managers. So I want to thank everyone, start it off by thanking everyone for this opportunity to attend my first 8th annual symposium, Women's Health Symposium. With that being said, without further ado, I want to pass this on to Dr. Swaget. Dr. Swaget, I apologize, I don't have your bio.
Are my slides going to go up now? Are they going to play my slides?
Yes.
Hello, everyone. My name is Khalid Sawaj. It's a pleasure to be here today. I would like to thank Dr. Pam Clark and her team for putting this together. Once again, a very successful event. I would like everyone just to sit back, relax. This is actually my first time giving a talk on mindfulness. So bear with me if I make a few mistakes, if I stumble along the way. Thank you. Next slide. So let me speak for a moment about what I do. I'm actually a graduate of Rutgers University right here in the city of Newark. Thank you, thank you. I love the city of Newark. I was happy to stay once I finished my residency, and I currently still practice in the city of Newark, and I will never leave. Thank you. Yes, very good, thank you. All right, so my talk today is on mindfulness. What I realized in preparing for this talk was I practiced mindfulness on my own, in my own special way. I'm one of those people that's very cool, calm, and collected. Actually a good quality to have when you're an obstetrician. But a lot of the practices that I'm going to discuss with you today, I actually practice on a daily basis. So I hope that you could take some of those practices away with you that can help you, in situations in life.
He's just saying it for 15 minutes. So
So what does mindfulness mean generally? So we're not talking about mindful, which is depicted in that picture up on the left. Many of us, when we're sitting down thinking, we're trying to meditate, our mind is full of, dozens of different thoughts. What did we do 10 minutes ago? What are we going to do 20 minutes from now? What are we going to have for dinner tonight? Some of us are looking around and just, looking at people and just kind of thinking about things, but we're not actually in the moment. And what we mean by mindfulness is actually being in that peaceful space where you could actually relax and be in the moment, enjoy the moment, and focus on what's happening right now. So the definition is a mental state achieved by focusing one's awareness on the present moment, while calmly acknowledging and accepting one's feelings, thoughts, and bodily sensations used as a therapeutic technique. Why should we care about mindfulness? Why is mindfulness important to us as human beings? Why is it important for us as a society? Because there are many activations or triggers in life that can cause us to be irritated, they cause us to be upset, they cause us to overreact, they cause us not to make the right decisions, and they can upset the people in our immediate surroundings. And it's very important to practice mindfulness, not only in the workplace, but at home, with your family, with your friends, even just driving your car. Mindfulness is a very, very good way to kind of keep your cool, assess the situation, and be a happier person for it. What are the different meditation types or different things that we can do to practice mindfulness? We can do something called focused attention. The focused attention practice builds focus and stability of mind. It involves choosing a focal point, such as the breath, and placing all of your attention on that focal point. Then, when you notice your attention has wandered, you simply bring your attention back to that focal point. It's very important to practice living in the moment. We all are distracted at some point in our day, at some point in our hour or the minute that we're in. As a matter of fact, statistics show and studies show that we are distracted as people 47% of the time, which means that almost half of our life is lived in a distracted moment. So we really need to start focusing on the present, on the now, and not worry so much about the past, not worry so much about the future. I mean, obviously we're all going to worry about the future, but we need to try to live in the moment. Another practice is the open awareness practice. The open awareness practice develops the capacity to stay present and observe whatever is happening in the moment. During this practice, you might be aware of a thought. In the next moment, a physical sensation, and then an emotion. Instead of attaching to any of these experiences, simply remain as an observer. And one of the examples that, in my reading on this topic, one of the examples that they give is if you're sitting in a quiet place and you're meditating, or you're just focusing on your breathing, or you're trying to get into that place where you feel very relaxed and comfortable. If there's something that is interrupting that, such as if you're sitting in your living room and all of a sudden the landscaper comes and he starts mowing the grass, do not focus on what is happening around you. Bring your attention back to what you are supposed to do and focus on the task at hand. And do not attach yourself to what's happening outside. You have to bring yourself back and practice practice mindfulness. Body scan. The body scan helps build a higher resolution awareness of the body, including the physiological signs of emotions. It's like being a map maker for your body, moving systematically from top to bottom or bottom to top, exploring every area to gain more awareness of what's there. As you scan through your body, simply notice and experience whatever is present without trying to change anything. It's really a practice of accepting who you are as a person. Do not focus on your inadequacies. Do not focus on your imperfections. Nobody in this room is perfect. Nobody in this room will ever be perfect. And the more we can accept that about ourselves, the more we can accept that about the people around us and be more forgiving. The Seeing Similarities practice builds compassion and awareness and understanding that we human beings are similar in fundamental ways, no matter how we perceive ourselves to be. Practice involves bringing individuals to mind and thinking phrases such as, this person has feelings, emotions as I do. This person has at some point been sad, disappointed, angry, hurt, or confused, as do I. This person wishes to be safe, healthy, and loved as I do. What we mean by this is, I'm sure you have all heard of the phrase, everybody has to put their pants on one leg at a time. It's sort of that concept. Everybody in this room goes through the same feelings and emotions that I do. Everybody in this room has moments of sadness like I do. Everybody in this room wants to be loved just like me. So we're all the same in those fundamental ways. Status like money, jobs, the car we drive, the house we live in, the clothes we wear is meaningless when you get down to the fundamentals. And that's the way we should be looking at each other. And we should not be judgmental of each other. And the closer we get to mindfulness, the more at peace we will be, and the happier we will be in our lives. Loving kindness, one of my favorite ones. The loving kindness practice cultivates compassion and focus on developing feelings of goodwill, kindness, and warmth. The practice involves using phrases or wishes that express the intention to move toward compassion and understanding of ourselves and others. As you bring yourself and then others to mind, repeat phrases like, may you be well, may you be safe and free from suffering, may you be happy. This is a practice that I generally do practice, and I always tell the people that I speak to, shower people with kindness. They will not fight you back. Shower people with love. Shower people with the good things. It takes more energy to dislike someone than it does to like someone. Just think about that. We waste so much time and energy disliking some people in our lives or disliking people at the workplace when all we have to do is show a little bit of compassion, a little bit of love, and it puts us in a better place. Walking meditation. The walking meditation serves as a bridge for bringing sitting into action. There's a typo in here somewhere. The walking meditation serves as a bridge for bringing something into action. The focus is walking itself, not walking in order to arrive somewhere. Practice keeping attention on yourself while walking, feeling the ground under your feet, the sensation of movement, your breath, your thoughts, your feelings as you move. It can help to walk slowly so you can be aware of those sensations. So when you do go out for a walk, don't be concerned about getting to your destination by a certain time. Don't be concerned about, things that just are really not that important. I think that when you do go for that walk, if it's a meditation technique, take your time, breathe, feel your breath, feel the ground under your feet. Just enjoy the task of walking. It's actually very, very puts you at peace, and it's good for your mind, good for your soul. There's something called 3 breaths, and what are the 3 breaths? It's a practice of taking 3 mindful breaths that can help you to refresh, to be present, to get off of autopilot, to make a choice about what to do next. How? How do you take the 3 breaths? Well, the first breath, complete yet gentle attention to the process of breathing. So when your first breath is focus on breathing, focus on the breath that you're going to take. In the second breath, let the body relax. I've noticed that when I try to relax my body, sometimes my facial expression is plastered to my face, and my facial muscles are actually doing work. And when I actually try to meditate and try to relax, I consciously try to relax every muscle in my body so that I'm truly relaxed. And in the third breath, ask, what's most important right now? What is most important right now? If you're home with your family is important right now. If you're at work, working, if you're taking care of patients, your patients are important right now. And if you're having a life crisis, then you are what's important right now. So you really need to ask yourself a question, what is important now, and focus on that particular aspect in your life. When are these practices important, and when can you utilize them, and when can they be effective? You can practice this before an important conversation. You could practice it when you feel triggered by something in life, before your transition from being at work to being at home. I know that that's a struggle for a lot of us. It's a struggle for me. I'm so busy at work. When I get home, it's like I'm not really home. And then when I'm come back from a long vacation or I come back from a nice trip, I'm not really at work. I think that we really have to know how to transition from being at work or home or vice versa. And when you have the urge to check your phone or social media, check yourself. Maybe in that moment, it's not so important to check your phone. Maybe in that moment, it's not so important to go on social media. Maybe you need to think about yourself in the moment and what's important in that moment. Mindful conversation. Build understanding of others by listening mindfully, then checking with the speaker to ensure that you've understood them by repeating back what you heard them say. How many times have you been involved in a conversation, even today? How many times have you been involved in a conversation, somebody's speaking to you, you hear their voice, but you're really not listening to what they have to say. You're thinking about, oh, who am I going to meet next? You're thinking about, oh, lunch is here. I'm hungry. I can't wait to eat. And you're really not paying attention to what that person is saying to you. I think it's extremely important to have mindful conversation. Mindful conversation stimulates your mind. It stimulates your body. It stimulates so many things that are positive in your life. And I think that if we pay attention to what people are saying and we have mindful conversation, we will be happier, and the person you're speaking with will actually feel much better. Acceptance. Whenever you feel distressed, take a few breaths in and out and repeat to yourself, breathing in, I do my best. Breathing out, I let go of the rest. Dr. Clark, are you in the room? Practice this with me. Take a deep breath in. Breathing, when you breathe in, I do my best, and as you breathe out, I let go of the rest. One more time, Dr. Clark, because you made me do this so many times at your meetings. Breathe in and breathe out. Breathe in, you do your best. Breathe out, you let go of the rest. Thank you, Carissa. Thank you. I have up here some practice, and I apologize if I'm rushing through some of this, but I was told to keep it down to 15 minutes, and there's a lot of material. I have some practice tips that I wanted to discuss because these are extremely important to get people focused. Consistent time. You will find it easier to keep going if you do your dedicated practice at a consistent time every day. Pick a time when you can have some alone time, and pick a place where you're comfortable. It could be when you get up in the morning and everybody else is asleep. You take a few minutes, you make your coffee, you sit in your favorite chair, you're comfortable, and you start your meditation. It could be at the end of a long day. It could be sitting in the car in your garage before you go into the house. Wherever that space is, wherever that place is that makes you comfortable, make sure you try to do it the same way every day, the same time every day. It helps. Do what you can. If you need to skip a day of meditation, skip it. It's okay. Like learning anything new, you'll feel highs and lows in your energy and motivation. Don't worry about it. If you can't do it for a day or two, don't beat yourself up. Just try to be persistent. Try to do it every day at the same time in the same place. Peaceful place. Pick a place where it's easy for you to relax and settle in. A park bench near your work, a special chair in your home, on the bus with headphones on. If you have that special place where when you sit down, your body is comfortable and relaxed and you can actually meditate and you try to do it at the same time every day, it will do wonders for you. Sit comfortably. Again, find that place where your body is going to be completely comfortable when you meditate. If you're feeling sleepy before meditating, move your body a little bit to wake it up. Maintaining, that's not marinating. I think we were cooking. I think Nancy, my wife, is in the audience, by the way. Thank you. I think she may have been marinating some chicken while I was making the slides. But maintaining good posture, sitting with your back upright and feet flat on the floor can help you stay alert. If you are still feeling too sleepy, then try walking meditation. If you are consistently sleepy, you may simply need more sleep. Listen to your body. Listen to what your body is telling you. But if you try these things, try these techniques, you will feel better. If you're feeling discomfort, it is normal occasionally to experience a little discomfort during practice, when you practice meditating. If you notice an itch or a little soreness in your body, try to sit with that sensation for a little while and observe it. Chances are it will disappear before too long. If it doesn't disappear, it's okay to shift your position, to scratch that itch. But if you do move, maintain your practice of attention as you do move. Do not put your focus on scratching that itch. Do not put your focus on, adjusting your body because you're uncomfortable. You have to focus in the moment on meditating, and that should be your focus. When all said and done, don't forget to enjoy the ride and appreciate all the work that you put in, because meditation and mindfulness is not meant to be work, but if you work at it, it'll become much more easier as time goes on. And I promise you, it will help you in your life, it'll help you with your spirit, it'll help you emotionally, it'll help you physically. And I think if there's a takeaway message from this talk that I gave you today, know what mindfulness is, practice mindfulness, respect and love the people around you, and I'm sure you'll have a much better day. Thank you. I could take any question on any topic. So again, this is the first time I've ever given this talk. There was a lot of material. I had to go through it and select what I thought would be fun and appropriate for this particular gathering.
I just want to remind them who you are. That this is Dr. Swajit. He's the chair of obstetrics and gynecology at Newark Beth Israel. And as you can tell, yes. And so what he's trying to tell you is that he's a physician who is culturally sensitive, and he's also able to modify the way how he provides care to include these kind of things to help his patient to do better. So he's telling you that he's doing this for the first time, but it's not the first time. Speaking about for the first time. Okay, good, I got that. Thank you.
So you weren't being mindful and paying attention.
I wrote it down. You're funny. But the key here is that this is what you should expect from your physician. You notice that? Right. You would never expect a physician of his capabilities to be talking about mindfulness. Did you realize that? So that is what they talked about earlier, in that you must expect different things from your physician. You need to have these kind of conversation, and the physician must be conscious. So we're very excited by that, Dr. Swajit. Is your question? Yes? Oh, there is a question.
Yes,
sorry.
Thank you.
Thank you, Dr. Swajit. That was a really great presentation, and we are all familiar with what is happening with our children these days. They're tuned in, they're on their phones and their devices all the time. So I think it's really important that as parents and adults, we practice these things, and then we teach our children also how to do that. So I want to share with you, I feel like Oprah, but this book is called Tia Bua Believes in Your Magic. It's written by Pooja Desai, who is also a woman of color, and it starts out with these lines. Sometimes when things aren't going my way, I close my eyes to save my own day. It's a great book that adults can read and children can read, and I gift it to you for your office when you have your meetings.
Thank you. Thank you so much.
Before he leaves, so he gets a gift from somebody who cares, so he knows that everybody cares about him. Are you
Thank you. Of course I am. Yeah, yeah.
And while we wait, we're gonna have Miss Julissa Garcia just come for a minute, because there are people who are in your health center or close to you who can help you to practice what Dr. Swaji just says. Breathe in, I do my best.
Breathe out.
I let go of the rest.
That's it.
I did listen in the
Thank you.
moment.
Thank you. Thank you.
So, yes, could you just yes, right. Thank you.
Hello, everyone. My name is Julissa Garcia. I am a traditional midwife and doula trainer here based in Newark, New Jersey. And I'm going to share a moment of a sacred pause, a practice of mindfulness. So as a birth keeper, sometimes there's a lot of decisions that families are making, right, when in their birthing journey. And sometimes you just have to exhale, close your eyes, let yourself feel what you're feeling. Sometimes they may look like crying or just emotions. Just regulate yourself. And the mindfulness is like, it's okay. It's okay to be in this moment. Give yourself permission to feel those feelings before making another decision that you're not comfortable with, right? Because we have to have informed consent, right? So mindfulness for me, what I teach my families is hold your heart. Have this moment of gratitude. Be still. Allow your mind to drift to a space of thinking of water, because water is very much of a healing element. Think of the sounds of the water. Think of how the water feels in your hand when you're washing your face, washing your hands, maybe at the beach, putting your feet in the sand, walking on the beach. Just sitting near water is so peaceful and allows the mindfulness practices, right? So if we are not privy to being near the water, how can we have those thoughts of connecting with those elements to calm all these emotions down, right? When we're in this birthing journey and there's so much information being thrown at you. So the mindfulness is really, really important to stay in tune with your pregnancy journey, to connect with baby while you're birthing, and being a wonderful, active parent. Thank you.
So you wanna end by saying how both of you work together, because you're the Indian,
So one of the things that we do, the providers, the doctors, is we work very closely with the midwives, we work very closely with the doulas, we work very closely with a lot of we work very closely with the doulas and the midwives, and we work with the patient, the patient's well-being at the center of our focus. And we as providers could not do the things we do without, the help and assistance of all of these other people that kind of come in and help us keep our patients safe. Sometimes, patients are not listened to. Sometimes patients, they need an advocate, and it's a very important part of healthcare. So thank you. Thank you for all the work that you do and all of your colleagues do. Thank you. Thank you. Anything else, Dr. Clark? Any other questions?
Any more questions? He has to go, but he will take one more. This is very good. This is totally different, a different approach to patient care. All right.
So just as a final comment before I leave, if any of you has ever visited a physician, a nurse practitioner, has ever been in a hospital, has ever felt like you're not being listened to or you're not being treated with the respect and dignity that you deserve, you should really advocate for yourself. And if you cannot advocate for yourself, there are channels that you can go through, because I can assure you, as a chairman of a department in a large hospital, in a very large system, all of these things do trickle down and get to me. And if anything like that ever happens in my area, I usually tend to it. I always tend to it personally. And you will be getting a phone call from me, first with an apology, and second with what can I do to make things better for you. So I don't want you to think that when you do go out and you do access health care, that you should have to tolerate any of those behaviors. And I know that Dr. Clark holds her doctors and her nurse practitioners and her staff to the same standards, but I just felt that that was a very important statement to make, because there's too many patients that are leaving their doctor's office dissatisfied with the care that they receive. Case in point, I was walking in, with my wife Nancy today, and while we're walking in, she was telling me a story about my nephew's future wife who went to see an OBGYN last week. And she was telling my wife how poor that experience was, how terrible it was. The doctor did not give her an opportunity to speak. She didn't give her an opportunity to ask questions. That's unacceptable. And the person I'm speaking of is actually a physician that went to see another physician. So it's happening. I just implore everyone to please, if you recognize it, advocate for yourself, advocate for your family and friends. It's not a perfect system that we're working in, but we can work to make it more perfect. And that's what I want to leave you with today.
Thank you. Awesome. Thank you, Dr. Swaj. Thank you. Another round of applause. Keep clapping him. He works very hard. Very, very hard. Thank you so much, Dr. Swajek. And remember, may you be well. May you be safe. And free from suffering. May you be happy. Thank you. Thank you. Thank you. Dr. M, Dr. Mahdi, on your team. Thank you.
All right. Thanks, everyone, and thank you, Dr. Sawajet, for that wonderful presentation. So without further ado, we'll call up, I see Dr. Roche and Dr. Giddens. Could you please come up? Very good. All right. So without further ado, we'll wait for our panelists to come up the stage, and we'll kick this off. Before I take a seat to join the panelists, I want to mention that in the first session, we talked about policies and procedures related to women's health and how we can improve that. In this session, we were just on around the table and talking about statistics, women's statistics related to maternal mortality and women's health. But I just want to let everyone know that in this panel session, we're going to try to link the statistics to clinical care we provide for our patients. So thanks again for joining. All right. So thank you so much. So welcome again, and thank you for joining us today for the 8th Annual Women's Symposium. Today we'll be addressing the root causes of women's health disparities. So I'll start first by introducing our panelists. The first panelist I'll introduce is Dr. Natalie Roche. She's a specialist obstetrics gynecologist at University Hospital. Dr. Roche, can you please tell us about yourself, a little bit about yourself?
You gotta talk into the mic. Can't hear you. Hello, first of all, I'd like to say that I do live in Newark, New Jersey, which is rare for some of these providers. All right, so I do believe in living where you work, all right? So I'm the director of general obstetrics and gynecology at University Hospital. I hold a lot of different hats. I will say that I'm also addiction medicine certified, which I had to get into that space because there weren't enough practitioners. We're not gonna spend any more time talking about me. I'll pass the mic because we wanna be able to answer a lot of your questions.
All right, thank you, Dr. Roche. Our second panelist is Dr. Lisa Gittens-Williams, OBGYN Director of Obstetrical Services at the University Hospital.
Thank you so much for that introduction, and thank you for having me here again. In addition to being the Director of Obstetrics, I'm also the chair of the New Jersey section of ACOG, which is the American College of OBGYN. And at University Hospital, I'm responsible for safety and quality. And that is so important because that directs outcomes. We make sure that we have teamwork ongoing and that we are practicing the most evidence-based medicine to ensure safe patient outcomes.
Wow, thank you, Dr. Gittins. That's very impressive. Moving on to the third panelist, we have Dr. Francisca Maramiku. She's the Clinical Director OBGYN at NCHC. Dr. Maramiku, can you please tell us about yourself?
Hi, welcome to the symposium. I'm so happy to see all of you and our panelists. Thank you for coming. We appreciate you. You came last year, and we appreciate. We hope you keep coming. So I've been with this organization for 12 years. It's a great place to work. They really cater to our women, and I'm really very, very happy to be here. And I hope we continue the work, collaborating with our colleagues to continue to offer the best healthcare, affordable healthcare in this community. And I want to thank you for coming. Okay.
Thank you, Dr. Maramiku. Moving on to the fourth panelist, Dr. Valerie Shaw, Chief Operating Officer at NCHC. Dr. Shaw?
Hi, good afternoon, everyone. Thank you for that, Dr. Amadi. It's a pleasure being here. It's a great conference. I have heard all the speakers, and I'm amazed at some of the things that we need to focus on, and I'll share some of that with you. So yes, I've been at NCHC 2 years almost, and it's been a delight. My background is in maternal child health as a specialist, and also can bring you lots of information as it relates to women's health. It's great that we're doing this because women are suffering, and there are much to discuss regarding how we can combat those issues and concerns.
All right, thank you. So without further ado, and for the interest of time, we'll start with our first question. So I just want to comment that, statistics have shown that women live longer than men on the average, but most times 25% of them live in debilitating condition. So with that in mind, there are a couple of challenges facing women's health in the United States and Essex County. My first question is, what do you think is the biggest challenge facing women's health? Who wants to take this on?
So I will speak. So in looking at the research regarding women's health, I was amazed to find out that in the United States, for example, let's speak about our health morbidity and mortality. We're 23.7% worse off than other industrial nations as it relates to healthcare of women. In addition to that, other industrial nations like Netherlands and all those countries are running between 1.7% or less. But more challenging and concerning to me is that we're hearing that in terms of maternal morbidity, right? The factor starts when we live in areas where there are no places for us to get great foods, where transportation is an issue. So I'm talking about all us for social determinants of health, right? So we grew up in areas such as that. We're not taking care of our bodies. We're not nourishing ourselves from childhood to adolescence, all the way to childbearing age. We have health challenges and issues that we are not addressing. So guess what happened? So now we have a baby, or we're pregnant with a baby. The body that we were not able to take care of in childhood because of where we live, our economic status, has continued to bring forth when we decide to start having a baby. Those health issues, whether it's hypertension, diabetes, cardiac issues, because they weren't addressed from when we were younger, plays a major part of it. I want to share with you that in terms of maternal issues, these are the factors. Let's deal with these social determinants of health that has plagued our population, and that's why we have these issues going on now.
Yeah, thank you. Thank you, Dr. Shaw. It's interesting that you could mention the economy. I mean, studies have shown that, in women's health, if we focus on preventive... Studies have shown that in women's health, if we focus on preventive measures, globally, the economy could, boost by $1 trillion. All right, thank you so much. Does anyone have anything to add to this? Dr. Rush?
Well, the thing that's most likely to kill all of us women in this room is cardiovascular disease, and that's across the spectrum. That means during pregnancy and then later in life. So we all have to remember, while people are so concerned about cancer and other things, that heart attack and stroke is the #1 killer.
Thank you, Dr. Rich.
Yeah, and I'll add to that. I think that women have to advocate for themselves when they present to the emergency room. It's there's a lot of data that suggests that women are poorly treated in the emergency room when they go with complaints, the way that a woman who is having a heart attack presents, and the complaints are very different than the way a male patient may present. So it's really important that you are focusing on your cardiovascular health. It is seriously the leading cause of death of women and a high cause of mortality in New Jersey for pregnancy.
Thank you. But another question I have for you is, why do you think, or what do you think is the reason the Black women are 3 times more likely to die from childbirth?
This is statistics that's out there, and the worst thing about this statistics is that we hear that 75% of these causes are preventable. That's the saddest thing about this statistics. When something is preventable and we're still dealing with it year after year, that's where the challenge is coming from. So part of what you got mentioned at the beginning is also contributing. So when a patient has comorbid condition like diabetes, high blood pressure, they're more likely to have complications during pregnancy. Having said that, there's some other areas that are preventable, and I think in general, for a woman, you have to advocate for yourself. And Dr. Bay mentioned something important during the channel discussion before. If you go into, he says something specific, which is, that was very powerful. If you go into a car dealer and they're not doing a good job, you wouldn't take your car back there again, right? So the same thing for patients, right? If you're seeing a provider, right, and you're telling them something about you and they're ignoring you, right, you can advocate for yourself and tell them, listen, I've been telling you this and you're not responding to it, right? Some people will say, oh, I didn't realize you were saying that, I didn't even hear you, and they're going to change. But some people will never change. So for you to continue to go to that provider over and over and over, and unfortunately you end up with something, maybe if you sue them, but at the end of the day, when you get in that vibe, like he's not going to do anything about what I'm telling him, and I've done A, B, C, and D, it's time to you to advocate yourself. The best advocation for yourself is to find another doctor that will listen to you. And that makes a big difference, in terms of outcome. Okay, that's what I want to add to that.
So I think this is what's termed gaslighting, right? Gaslighting, meaning, most women, when complaining of some serious symptoms, shoved us up having mental illness, which, isn't really appropriate. So with that being said, does anyone have anything to add to this?
Yeah, I just wanted to add. So to your point, it is gaslighting. What we have seen in the literature and just in terms of our Black women, when they go into see their provider and they describe symptoms that they're having, they're not really taking seriously some providers, right? In addition, what we're finding is that when they describe the symptoms, because some of the symptoms are so close to other illnesses. For example, if I go to the doctor and I said I'm having pain and I'm having, not feeling so well, those symptoms are similar to sepsis, right? So the doctor will say, okay, because you just had a baby, you had your episiotomy, that's probably from what it is. But technically, I now have an infection. So we're not focusing on the infection. They're not listening. They're not being treated. And then you have the issue of what the outcomes with the mom. I want to share with you that 22% of women dies during childbirth or on day 1. 23% dies between day 1 and day 7. And 53% dies between day 7 and 1 year. That's where the issues are that we need to focus on, because that's a big concern. And we'll continue more about that. But yes, because no one is listening, gaslighting is a real issue.
About gaslighting, I think this really happens more frequently in women. With that being said, how do we improve disparities in healthcare?
I'll start on that one. So the disparities in maternal outcome are clearly multifactorial. We talk about chronic conditions like diabetes, hypertension, cardiovascular disease. We talk about social determinants of health as to poor access to care, lack of transportation. But remember, if you've watched the news, and most recently, anytime a celebrity or high-profile woman has an untoward outcome, it is in the news. So a few weeks ago, one of the Kansas City Chiefs cheerleaders passed away in pregnancy. And so those stories, just like the story of Serena Williams, who is clearly alive, but she had a pulmonary embolism and a deep venous thrombosis, and other high-profile black women that have died are in the news. And so it's not just not economics, it's not education, it's how you're treated at the healthcare interface. So it is actually how black women in general are treated in society and then also in healthcare. So this is a systemic problem, and the systemic problem is systemic racism. And the healthcare system was built on that type of systemic racism. Black women were experimented on, in fact, to develop gynecological procedures. Betsy, Lucy, and Arca were slave women that were experimented on for doctors to learn how to do gynecological procedures. So the entire healthcare system, including making decisions about treatment based on race. If you're black, you should get this kind of treatment. If you're white, you should get this kind of treatment. Race-based algorithms are all now, it's tumbling. So we have to tumble down this house, right? We have to tumble down this house, and then we have to teach things differently. So we need advocacy, and we need a more diverse workforce. So what else can we do? We need a more diverse workforce. We need doulas, and we need midwives, and we need a diverse workforce because we know that in the workplace, when we have diversity, we develop tolerance and we understand more about one another. The White House Blueprint for Maternal Health clearly states that the maternity workforce is woefully understaffed, and there are maternity deserts. So throughout the nation, there are places where there are no obstetrical providers for miles. There are counties in the United States where there are no obstetrical providers. And even in densely populated areas, there may be no obstetrical provider that takes your insurance. So that's also a desert. So until we address the systemic problem, we won't improve maternal health.
Thank you. Dr. Rush?
I'd also like to say everybody's talking about the patient advocating for themselves. Sick people have a very difficult time advocating for themselves. The more severe your illness, the less capable you will be of being able to do such a thing. So people really do need a support system What we as a community have to really value our pregnant and birthing parents in a way that is greater than what we have been doing. No pregnant person should be living alone. They should not be laboring alone. They should not be bringing a newborn baby home alone. And the reality is, if the person who made them pregnant is not available, then we have to, as a community, find our way to that person and provide support. All right? So the issue is a community-wide one. Birth warning signs are something everybody in the minority community should know about for pregnancy and for postpartum. So you could be standing in ShopRite with somebody with a baby, a newborn baby in a carriage, and if she has certain symptoms, then it's our responsibility to say, are you okay, madam? Can I help you? Maybe you need to go to the emergency room. So it's a community-wide problem. It's not all can be borne by the pregnant person themselves. So we have to understand that if we want to continue as a people, then we have to support our pregnant and birthing people.
And then just to add to that, that's why organizations like Newark Community Health Center, where patients get their care, where families get their care, where grandmothers and children get their care, can be the foundation for providing that education and creating that community. It doesn't necessarily happen all the time in the tertiary care center. You come to the tertiary care center because there's a trauma, or you go to the tertiary care center because you need a liver transplant. But it is the community that has to be the foundation of improving this maternal health and assuring that every birthing person has a community, that they have a doula, they have a support person. And so at University Hospital, we ask about a birth plan, and we make sure that everyone that comes in has a support person. We ask about that early and prenatal care. And if they don't have someone, we try to find someone. To Dr. Roche's point, you should not birth alone.
Thank you. Thank you very much for that. So there's been so much emphasis on maternal health with mental health being linked to it, especially postpartum. So how do we as physicians address mental health challenges in women? Dr. Marmiku?
Go ahead.
So I need to say at Newark Community Health Center, we're doing an amazing job with the social determinants of health and addressing them on every visit. When someone comes in, we're asking the question, what are some of your concerns? What are some of your issues? Do you have transportation? Do you have food? Do you have someone to assist you? But the idea of utilizing other resources as well, having our doulas to go in and support our moms, that's amazing. So there are a number of bills in the federal government right now looking at training more healthcare individual midwives as well as practitioners to go in and provide more support to the maternal, the patients who are having a baby. But in addition, they are putting funding to doulas, to create more doulas as well. So those programs are being launched. Some of them are still being being voted on, but there's a number of programs in there, in addition to programs for nurses to be there as well, and providers as well. But in general, though, we need to address these issues, and I think when patient comes in and say they're pregnant, we need to get to the bottom of it, right? Deal with some of the concerns, deal with the issues at hand, and address them early as opposed to late on missing the symptoms. But I think our OB department is pretty aggressive. We don't leave any stones unturned. And when we see something, we refer to the high-risk providers as well.
I know at NCHC we do have centering pregnancy. Dr. Maramiku, do you want to emphasize more on that? On how it's related to addressing mental health?
Yes, so mental health challenges are real, especially in obstetric and postpartum period. It is real, okay? I tell moms that part of the mental health, of not official diagnosis, but I make a point when I see couples come into the office and they start to argue. Actually, this is actually a real conversation. So the guy was telling the woman, "You're the most selfish woman, on earth. You're so self-centered." I overheard it. I was getting ready to come in, and I overheard this conversation going on, and they were arguing. And she was, "You're just so selfish," So just emphatic arguments. So I just, quietly, listened, but not letting them know I was listening. So when I came in, opportunity to educate this guy in a nice but polite way. And I just told him, I said, "Well, hi, how are you all doing? Are you having a good time?" Just pretending like that. And as soon as I came in, they both stopped. So I explained to I said, so at this stage of your pregnancy, in addition to the nausea and vomiting, just remember that your hormones are going to try to control you. So this is where the partner will, bear with you and understand that the hormones are acting out sometime. So I told him one of my actual patients, she came in, she said she was, she was so much angry during her pregnancy that when she's vomiting, her husband, very nice guy, will come to her and say, "Oh, you vomiting? Don't you think I'm trying to vomit?" I told them that story. They were like, "Wow." So the reason I'm saying that, in addition to the hormonal state that can really affect a lot of your day-to-day activity, I'm just saying this in a nice way, that, we have to educate the patient as well as the partner about this condition. So having said that, I'm going to go address the main issue about the mental health. So for moms, mental health challenges are real. Unfortunately, some of them are not going to answer your questions correctly because there's a stigma. If you ask a mom, some of the moms, when you ask them, "Are you having A, B, C, and D?" they'll say no. They'll answer no to all the questions, right? So based on that assessment, you're going to say, "Oh, she's fine." But when you get them into the room and then you change the method of questioning, you realize that they're mentally really either depressed or anxious or something is going on. Currently at NCHC, we have the behavioral health component, the Cherokee model, where we have the behavioral staff person come and speak to the patient. So because the mental health issue is real. You've heard the story about the Texas mom that drove her children into the river. Few months, it was about a few years ago. So this is real. So that's why we need the resources. We have our healthists that I don't want to say that, to reach out to the mom in addition to them coming to the office. But I think they have to come back after the delivery. That's so important. That's a big component. It's good to send the nurses and the doulas to see them, but there are some things that a physician will see just by looking at a patient 1 second that no one else will see. So it's so important that we put in resources to bring the moms back to see their physician or midwife, after the delivery. So important. So right now we're trying to get resources so that we have this ammunition to bring all the moms back, because mental health issues are very real. You want to add?
Yeah, thank you for that. That is really so very important. So most of the maternal mental health deaths occur actually 42 days to 1 year postpartum. And so that's after the patient typically has finished with her obstetrician. So that is where, again, these community health centers and primary care come in. You might be seeing that mom. The pediatrician might be seeing that mom. So perinatal mood disorders not only include depression, but that includes depression, anxiety, obsessive compulsive disorder. I had a mom that said that she couldn't drive the car across any bridge because she felt like whenever she crossed the bridge, she was going to get out of the car and jump into the river. So unless you're actually asking about these questions, you won't get the answer. It's not all a depression that's going to come up on the depression screen. And then there's the cultural component, because many cultures Depression is taboo. Any type of mental illness is taboo. The culture has not accepted it. They are stigmatized. So a mom may be afraid to answer those questions. Mom may be afraid to tell her partner that she's having obsessive thoughts or that she's having anxiety. So there's this entire cultural component of mental illness where it's really stigmatized in a negative way that prevents moms from acknowledging it and or letting their provider know that they have or that they're experiencing some type of perinatal mood disorder. So we need to improve the workforce. There's actually a national hotline. It's 1-866-HELP for Moms. That's a national hotline. In our practice, we try to give the moms that card. You can print it out from the website, but there's almost a pocket card that moms can keep when they're getting discharged postpartum. Mood disorder is one of the maternal warning signs that we want to tell the families about, so if they can notice. And the other thing is actually also cultural, because the mom who is depressed, depending on her culture, she's not going to come to your office looking disheveled, because even today I told my daughter, you're not going outside looking like that, we're going outside. You get dressed when you go out. So as Black mothers, or depending on the culture, we may just always show up a certain kind of way. And so no one's going to know that we are feeling badly unless we ask those right questions.
And of course, I'd like to address the elephant in the room. We can say whatever we want, there's just not enough mental health care providers around. And there's certainly not enough that are culturally competent to deal with the patients that we have. So we're going to have to look at ourselves in the mirror and decide whether we're going to have to get extra training in order to be able to handle some of these problems, as I had to do with addiction. I couldn't find anybody, so I just had to go get trained to do it myself. So the reality is that we're really going to have to look at ourselves. The idea that you're going to ask a mother of several children with a newborn baby to go to a psychiatrist, which maybe the appointment will be 6, 8, 10 weeks away, to someplace else, is really unreasonable. I myself think the system is incorrect, because this kind of psychiatric care should be embedded in the OBGYN care provider's office. That gets rid of a lot of the stigma. I have an example. I used to do this care when I was back in New York. We ran out of the funding. I left. It fell apart. But we had a robust psychiatric practice where not only did women go, but also the men went. And men came for individual care in the OBGYN practice because it was destigmatized. Where are you going? I'm going with my partner to see the gynecologist or the obstetrician. And they went into the psychiatrist's office and got their psychiatric care. So we have to rethink how we organize the system to get rid of some of these barriers, both for time and for stigma.
Thank you. Thank you very much, Dr. Rush. That was well said.
Centering pregnancy, for the people that are not familiar with this is a decentralized, right now you see your physician you one-on-one, but the centering is like a decentralized prenatal care where we see all the women in a group. And the moms, we really don't teach them. We have them share their experience while the moderator guide what they're saying. If somebody says something wrong, then the moderator in a nice way will make sure that they correct that. So you educate them without enforcing or teaching on them. You just empower them to take care of their prenatal care. And we found out that through this centering pregnancy model, we have a lot of great outcome. A lot of the patients deliver naturally because of the centering and the education. I don't want to use education, the empowerment, that's the word. So a lot of the mothers come back for their postpartum visit. A lot of the mothers get nutritional counseling, and also mental health is addressed. So this is an excellent model. We're about to restart it because during the COVID, we had to hold it for a minute, but right now we're about to restart it, and it has, shown to have an excellent outcome. So just to give you an example, one of the patients that I was, in the centering, she came in, right? And normally I would, we will address the importance of, hydration, pure hydration, which is very important in a pregnancy. So one of the patients during the group, she told them, she said, you know what, Dr. M, now I know what the hydration, how important it was. So she said, at 2 o'clock in the morning, she was having severe pain. She was contemplating going to the emergency room to go, call an ambulance. Then she remembered what we talked about. And she went and got a giant glass of water, and she drank the whole bottle. And the pain just went away, and she went back to sleep. Never had the pain up till now. So all the moms were like, wow. So this group, I never had to tell them anything about drinking water anymore. So centering is so important. It's a good forum to communicate, the prenatal care. We want make sure we go through all the prenatal care level, but in a nice, decentralized forum. So that's what the centering is about.
Yeah. So I think that's a great question. I mean, to add to that, I think during centering, it's a time for the patients to bond with the providers and the case managers and all that is responsible to making sure that mommy and baby are okay after delivery. So thank you for that, Dr. Maramuku. And
I'd just like to add that in centering, the patients also bond with one another. I've had centering groups where these women become really close friends. They watch each other. They create that community. Sometimes patients will come to the office and I'm looking for another patient and they tell me, oh, no, she delivered. She went here. This one, she went to visit her grandmother. They all connect to each other and, they create that birthing community that we talk about that can save lives.
Precisely, and I think that also helps with their mental well-being. That's
Yes,
great.
exactly.
All right, thank you. Great answers. All right, so the next question I have is, I know statistics have shown in the United States that there's high rate of maternal mortality postpartum, although it's improving. But my question is, why do you think that America has poor maternal mortality rates compared to other developed countries?
I didn't hear the
Who wants to take this?
What was the question?
Why do you think that, in America, why do you think that America has poor maternal mortality rate compared to other developed countries? Sorry.
I think it has to do with addressing some of those social issues that we're speaking of. In the U.S., you have concerns, issues with not addressing these health challenges that starts in our babies. Then it goes from babies to our adolescent, from our adolescent to adulthood, and then of course we become birthing moms. In addition to not addressing these social determinants of health in a timely manner, these things are affecting us. In other industrialized countries, they put a lot of monies into healthcare. In fact, some of them have universal healthcare. And so with universal healthcare, like in Canada, although you're paying a higher per tax and capita, you have universal health. In Europe, in England, they have universal healthcare. Remember when I was traveling in London in the cab, and I might have told this story before, so please forgive me, the cab driver said that they pay 45% of their income to taxes because they have universal health care. The only problem is that there's a long wait list to get care because, care is given to everyone and you don't have to pay as much out of the pocket. So it's the health care structure that we have here, and that's the concern. And until we look at those structures and try to change them, we will continue to have the issues we're having. Addressing the social determinants of health earlier, and we can because we have the finance and monies to do that, but we choose to put the monies elsewhere. That's my response.
Anyone else?
I just want to remind everybody, we spend more per capita on healthcare than anybody in the world, and these are our outcomes. Yes. All right, so our problem is we spend a lot of money on sick care and very little on preventive care. So if you don't want the diabetic, the hypertensive, then you work on preventing those things and controlling them so that you don't end up with the stroke victim and the heart attack victim. So in this fee-for-service world we live, where we are driven by the economic reality that healthcare is a business, then you do not redistribute your resources in a way that makes the most sense in order to get the greatest outcome, all right? So we have some basic issues about how we fund healthcare, and until we address those issues, we're going to be stuck in this reality. And I hear over and over again that we as minority people suffer so much from our poor obstetrical outcomes because of poverty issues and lack of education. But the results, the actual statistics show that a high school dropout white woman will have a better outcome than a college-educated black woman. So your black skin is your problem in this country, all right? Now, everybody doesn't want to talk about that because that is just too scary to actually deal with. You can be as educated as you want to be, you can be wealthy, and you will still get a poor obstetrical outcome because your black skin is the determining factor, all right? Now, who's been in the healthcare system? We've worked in the healthcare system, been in the healthcare system. I took a poll of 8 obstetrician gynecologists, black women, and asked them to tell me what their obstetrical outcomes were. They were horrific, all right? These people were doctors when they had babies. Stillbirths, miscarriages, preterm deliveries, eclamptic seizures. The only one who had a white woman's outcome, normal vaginal delivery at term with 2 8.5-pound babies, was me. And I said to myself, what is the difference between me and them? And the difference between me and them was when I went to labor and delivery and had a baby, I had power. Power. I ran a clinic for the first baby, and the second time I ran the obstetrical unit. So when I came there, they treated me like I was a white woman, regardless of my black skin. All right? So the reality is that this is our world. All right? And we have to sit here and fight against that kind of treatment. And it is difficult for educated women to pull off. So for women who have less resources, it's really, really hard for them to do. The bias is in the system, but it's also unconscious bias. They think we are worth less. If you're worth less, then they make less effort on your behalf. This is just the way it is, all right? Now, we're supposed to be going around trying to suddenly teach these people that are providing most of the health care, which is not us, to value us. That's a heavy lift and probably will never happen in my lifetime. So we're going to have to figure out ways that we can make demands, all right? I wish every person could be the way I am. I have no fear of white people. I have no fear of white privilege, and I will challenge you every step of the way, and you're going to give me the outcome that I expect. But that requires this kind of attitude, which is very difficult for people to embrace when they are suppressed generation after generation, all right? So I know that this is not the science, all right? But I'm going to tell you this is the absolute truth. The system will not change itself. The system was set up and designed for a purpose. They do not value you. They do not want you to live. They don't want you to reproduce, all right? Because once you were no longer a slave and would not work for free, you lost value, all right? Okay? That is our reality. So we have to force the change in the system, and they're not going to give it easily. We have to demand it. Women used to be strapped down in 4-point restraints with leather restraints, scoped out and doped to deliver. How did that change? It wasn't that the people who were male-dominated who were delivering them suddenly woke up one morning and said, oh, this is not the proper way to be. The women said this to the healthcare system. If you will not stop doing that to me, I'll find a woman midwife somewhere, and I will not go to your hospital, my insurance will not pay you, and you will not be able to earn a living. And that's the only way the change happened. So I know that this sounds a little radical to you all, and we're going to talk about all these nice things, but this is the only way to make change in this system.
Wow. Well said, Dr. Frank.
And on that note, I want to advocate for anyone in this room who knows any students, any college students, high school students, middle school students. We have to create a pipeline of providers. Less than 5% of providers, doctors are black, and the numbers are even lower for black men. So unless we create a diverse workforce, and then I also shout out to the doulas and the nurses, the entire healthcare workforce has to change. And that can be part of the system change that will allow women to be treated differently in the healthcare space.
Those were well said. So moving on, speaking about maternal mortality, as clinicians, what are the most common risk factors you've experienced in your practice?
Risk factors for mortality.
Most common risk factors?
So the leading causes of maternal death include cardiovascular disease and hemorrhage and hypertension. And then depending on the timing of the death, and then as I pointed out before, in the postpartum period, 42 to 365 days, mental illness and substance use disorder. And we already heard that 85% of these maternal deaths are preventable. So hypertension and cardiovascular disease is a really big problem. The rate of hypertension in the nation has been going up. The rate of hypertension in black women has been increasing. We could say that it's attributable to obesity, diabetes, but there's also the stress factor, chronic stress. So hypertension has been going up, and maternal death is higher, even for 15-year-old women have a higher rate of hypertension. A 15-year-old black girl has a higher rate of hypertensive death than a 15-year-old white woman. So those are the leading causes, and so as we begin to address chronic illness by interconception care and by adequate prenatal care and by excellent primary care, that's how we'll begin to address those things.
Thank you. All right.
Thank you, Dr. Gittens, for that. So also, to add to what Dr. Gittens just said, preconception counseling is also key to addressing all these diabetes, hypertension. So community outreach to educate the mom, or if they're coming to you, even to the pediatrician, or they're coming to you for general OB practice, I usually ask them, what is your plan? If I ask them, how many children do you have? And then I ask you, what is your plan? When do you plan on having a baby? If they're 35, I'm like, what are you waiting for? And then I ask them, what are your plans? If they're coming for birth control, then I educate them and tell them that, listen, the chances of having a baby when you're 35 is going to get less and less. You're born with all the eggs that you need to have a baby with. So every single year adds 1 year to your cycle. So if you're planning on having a baby, this is the time to do it. Or, or do you want your partner to have another person have the baby for you? So once I start to add that question, it becomes, they try to address it. So this is an opportunity. It's a kind of joking way to address something serious. So that if they have high blood pressure, or if they have diabetes, that is the time to actually control it so you don't have this poor outcome. So like you said, it's a combination of factors that cause the mortality and morbidity. But if we can take it one day at a time and then get us to take care of us, get your provider to be like you, that knows what's going on with you, that with all this combination of factors, that we're going to have the better outcome.
Thank you.
Yes. I'm always a little afraid for my moms that are over 35, because the mortality rate for women increases significantly with maternal age. And so many women are having their careers, they postpone their childhood, they postpone childbearing, they are getting a PhD and getting educated or working. But the maternal mortality rate is like 105 per 100,000 for women over 35, compared to in the 60s for younger women and down in the teens for other populations. It's a really big difference. And that is because of more chronic conditions as we age. So it's really important that women understand that. There's nothing wrong with deciding to have your baby at 35 or 45 or 48 if that is your sole desire. But you should really understand what those risks are and be in the hands of a provider that can see you through.
Great, thank you. So the last question we have today is, how do you bring your mothers back for postpartum visits? Because I know that that's the challenge we seem to face most times. So,
go ahead.
Yeah, so Dr. Rush or Dr. Gittins, do you want to take this?
Yeah. So there's a couple of ways that this should be addressed. And one good way is that the state of New Jersey actually has made postpartum visit a quality metric. So when quality metrics are made by the state, then organizations fall in line. We know that the American College of Obstetrics and Gynecology recommends that all women have a postpartum visit within 3 weeks because most mortality occurs in the first 7 days postpartum. The mortality that's going to occur outside of the hospital, the highest rate is in the first 7 days. So we want to get those moms back within the first 3 weeks. Moms that have hypertension, we want to have them back in a week to make sure that their medication is properly controlling their blood pressure, that they don't have preeclampsia or another condition which can make them have a stroke at home and be found deceased. So to get those postpartum visits in order, one way is to assure that those visits are secured at the time of discharge or even before discharge. That is one strategy. Other organizations are using visiting nurse services, calling the patient. Some places do text messaging. This year at our ACOG meeting, we had a presentation from the University of Pennsylvania where they were doing a text messaging to moms, asking them what their blood pressure was. It was actually very robust, and they found that patients actually liked it, in fact, better than coming in person. There's telehealth. So there's many ways to reach a pregnant or a birthing person. We just have to use the technology that actually is available to get them to come in. ACOG recommends that after that first 3-week visit that there's a comprehensive visit within 12 weeks where multiple problems can be addressed, including sexuality, sleep, contraception, whether or not the mom is incontinent, whether she has pain, if there's any substance use disorder. Those are all of the recommendations at that visit. But then lastly, what we've been focusing on at University Hospital is that transition of care to primary care providers, because that's the way that you'll have interconception care and then you can best manage those chronic conditions. There's actually a paper that came out just recently talking about a program that did something similar, and they reported very robust outcomes. So the primary care and the community health center is the resource for that. Getting those moms, after they see their obstetrician, back to the primary care providers in the same organization. Other opportunities are to partner the infant visit with the maternal visit. Some organizations are doing that. Bring the baby and see the mom. I had a patient recently when I said, "Did you bring your blood pressure log? And can I see it?" She said, "No, I showed it to the pediatricians." I was like, "Okay, good, it's working." So you want to try to partner those visits and teach primary care providers about obstetrics. In the internal medicine literature, there's a paucity of education on obstetrical care. And some are working on that, trying to get the curriculum changed so that internal medicine providers in their training learn more about obstetrical care and postpartum care. So we also need to educate our colleagues, the emergency room, the primary care providers, about how to take care of postpartum women and what those warning signs are.
So on the educational side, also at Rutgers, we have an internal medicine residency that has a maternal child health arm. So these people are being trained as internists with a focus on pregnant and postpartum patients, so they actually have some expertise. And we would love to see that kind of training duplicated all across the country so that you're graduating internal medicine people who actually do have knowledge and expertise so that they can identify, understand the importance of getting those women in, understanding what are the major killers of women in the more remote postpartum period where they will be taking care of the patients. And then we also need to educate, of course, our emergency room people. So every woman who comes in who's reproductive age, they should ask them, have you recently been pregnant, regardless of the outcome, so that they can have that higher level of understanding about risks for those women.
Thank you, everyone. Please give a loud round of applause to our panelists. So, all right, well, thank you. That was very informative. Again, I want to personally thank our panelists for being here. I know, Dr. Giddens, you're short of time, but thank you very much for being here. And thank you, Dr. Rush, Dr. Meramiku, and Dr. Shaw. Thank you. So thanks, everyone, for attending this wonderful session. With that, I'll hand this over to... Oh, any questions? I'm sorry. Does anyone have any questions for our panelists? Use this.
Hi. So there was an article that came out in Times Magazine in April titled "The Poor State of Postpartum Care in America." It stated that 88% of women felt that they weren't prepared for postpartum. Do you think educating women in their beginning prenatal phases, would turn out better outcomes for postpartum care?
I think absolutely. I think women are, they say the mom is the wrapper and the baby is the candy, and then after the baby comes out, everyone is focused on the baby and the mom's not even taking care of herself. I have moms that really need to come to their postpartum appointment. They miss it, but I see them walking to the NICU, and then I say, hey, you missed your appointment. Can you come back? So everyone is focused on the baby. And so there are moms that are extremely more vulnerable. Those would be those moms who have a preterm birth, or those moms that have a baby that needs a cardiology follow-up, because the mom is so focused on the baby. So educating moms about the postpartum period, that's what those post-birth warning signs are. We have postpartum doulas. There are doulas we have doulas in the room. There are doulas that focus exclusively on the postpartum period. Now we have extended coverage for maternal care insurance in the postpartum period. All of those things will help get better education out of the postpartum period. And while pregnancy and birth are important, and we can control the environment in the hospital by taking care of hemorrhage and knowing how to treat hypertension acutely and training our trainees, our residents, and our nurses. But that postpartum period when the mom is out of that space is really critical. And so I think that, and since we know that 53% of those deaths occur in that period, we do have to focus on it. I think postpartum education is really important. I wish somebody would TikTok that.
I want to add a little something. So you're absolutely correct. Education. And then you educate the patient at their level. Some of the patients, all I have to tell them, I say, you know how the stomach is so big? Because the uterus went out of its place. It's displaced now. It went out from the pelvis to go here. So when you have the baby, this is the time to make sure everything is going back to normal. They're like, oh, wow. So I really need you to come to make sure everything is going back to normal. So sometimes when you educate the patient at their level, that will really empower them. So when they come in, they're going to ask me, the first question is it going back to its normal level? So that's so powerful. It's so simple, but it's powerful. Educating the patient at their level so that they will come back. Okay, I'm not going to.
And I think we have a problem with our culture, all right? We have this nuclear family where it's the parents and the children and nobody else. And there's something really fundamentally the matter with that picture, right? And some of these other countries, even when they are high resource countries, do not function in that way. All right, they are real advocates for pregnancy and parenting, and they put their money where their mouth is. 6 months, a year off from work to parent. You know, time off from 20 weeks gestation to gestate with pay. So we fundamentally have cultural issues about saying we value motherhood, and Mother's Day just passed, and actually putting our money where our mouth is. So we make motherhood a commodity, and therefore they want to sell the stroller and all these other things, but we will not really truly support motherhood. And that is a fundamental and basic issue. The question you have about what to expect in these problems with the postpartum period did not happen even 25 years ago, all right? Because the family supported the woman postpartum, and there were less women, I hate to say this, I myself am a woman who's worked all her life, less women in the workplace, so they could go home and breastfeed and gestate and do all of these things, and expect to be financially supported. So we really truly have to ask ourselves as a culture, do we even think that having, children is any importance whatsoever? Because if the answer is yes, then everybody vote, everybody run for office, you women, and you have to legislate these problems out of existence. And you're going to do that by doing paid parental leave. We just have a rule that now you can take time off to get your prenatal care and not be penalized economically, that you can do time off for that. But women actually need more time off from work postpartum.
Thank you, Dr. Roche. As I stand here listening to your response, I just have one question in mind. Is there room for the father to get some education? I only hear, maternal education and all those things, but let's be realistic. In some homes, men mostly don't understand what the women are going through, and there's some form of domestic violence. So is there room where, the father will be included in that education to help know how to support his wife?
Oh, absolutely. And so that's where, education starts during the prenatal period, education starts in the interconception period, in the hospital. All of the post-birth warning signs should be delivered to the entire family. And men have to know that they, depending on their employment, they may be eligible for family leave. And so whereas fathers staying home with their children was previously stigmatized, there are more men now that are availing themselves of that. So they need to know that that these things are options.
And the rule they made that they're supporting prenatal care did not say that the male can have time off from work to come to the prenatal visit, okay? And therefore, some of these gender-based differences also have to disappear, because there was no reason why whatever the parenting pair are, that both did not get that leave to come to the prenatal care, right? Because then if we don't have the other person with us, how are we supposed to educate?
Absolutely, absolutely. Thank you. I mean, just something personal. I remember when I went for my first ultrasound, the doctor refused to do that unless my husband came from work to stay with me. So that was very interesting. So thank you, Dr. Rush, for that.
Yeah, I just wanted to add that before we used to have the men come for centering as well with the wives. We used to have that.
So I think that's something we have to bring back.
We used to have fathers programs, but particularly young father all the funding cut. So again, you got to put your money where your mouth is.
Absolutely. So we'll look into that for NCHC.
Yes.
Oh, question? All right, great. Come. Thank you.
Greetings, everyone. I am Asha Akwe-Halsey, a project manager at Ancient Song Doula Services. My question is that how can we as a community, as I look around, there's a lot of Black women in this space, be supportive of what's going on in the Black maternal health crisis? How can we spread the word? How can we support you guys as you're doing your work every day? How can we get this information up and out into the world so that we can be heard and go to spaces of policy to make sure that we do get this funding? How can the regular everyday person that's not physically working in this space but is experiencing all of the things that are happening in terms of the Black maternal health crisis and support you guys?
Well, I want to remind everybody, this is an election year. She's asking what can the community do to try to support some of these issues. This is an election year, and everybody's focused on what's happening at the top, at the federal government and the president, but all politics is local. So the reality is that you start by participating in local politics, what's going on in the city, what is happening in the county, what is happening in your state, because you want to influence how those dollars are spent in your community. If you don't vote, if you don't speak, if you don't try to put candidates who think maternal health and women are important, then we will sit where we are, all right? Because the money will be diverted and go on to other things, all right? So remember, register and get people out to vote. So if the one thing I would say, if you want to affect this, is to do that this year. This is an election year, and make sure you ask every single candidate, these are the problems that women have, these are the problems that Black women have. What is your policy? What is your platform? What are you planning to do about it?
Any other question before we wrap it up? All right, well, thank you. This was a powerful discussion. Thank you, Dr. Roach. I appreciate your coming here. Thank you, Dr. Giddens, and thank you to all the panelists and everyone. With this, I'll turn this over to Dr. Clark, our President and CEO.
Thank you, Dr. Marty. Thank you, Dr. Gittens. She's walking out the door with her flowers. She deserves it. Give her a round of applause as she goes out the door. She works very hard, very, very hard. Dr. Roach, thank you so much. You work very, very hard. Dr. We know. Dr. M, you work very, very hard. Dr. Shaw, very hard. And thank you, Dr. Marty. Okay. Did you learn anything today? Did you all qualify? Did you get your passport? What is today's session all about? Mindfulness, your passport to health and happiness. Yes. Did you get the passport? Did you hear all that was said by the panelists today? And do you understand it and you plan to do it? Did you all say yes? You're now at customs, remember. You got your passport, you just traveled around, you're at customs, and the questions have to be answered. So the key here is this, and Dr. Rose said it. This is an election year. Go out and vote. Your vote matters. And you have to find the candidate who is going to help you. But most importantly, please remember about communicating with each other, right? The question is asked, what are we supposed to do? You know what you have to do. Are you talking to people in your homes about these issues? Are you talking to your children about these issues? When you see the neighbor next door, are you talking to them about these issues? Think about it. Think about it. You have to start to have these conversations, not just in your head, but you need to talk to the right people, to your neighbor, to your children, everybody, and you have to talk to your local representatives and let them know how you feel. Most importantly, when you go to the provider, make sure you go. You need to talk to them and raise your expectation of what you demand from your provider. Let them know. Use your indoor voice, no shouting and screaming. But if you realize that your provider is not treating you the way that you should be treated, you need to let them know
don't be very rude and violent. Just be calm and just explain to them, this is what I expect from you. And after you explain to them what the expectations are, and if you choose to go back to them, you should expect the next time round that whatever you ask them to do, they're supposed to be doing it with you. Don't you agree? All right. So, listen, we've come to the end of our presentation. We've heard about all these disparities. But these disparities underscore the urgent need for targeted interventions and policies to ensure equitable access to quality health care for all women. Let us carry forward the spirit of empowerment and solidarity, recognizing that every woman's health journey is unique and worthy of respect and support. Let me repeat that. Recognizing that every woman's health journey is unique and worthy of respect and support. Together, let us continue to strive for a world where all women have the resources and opportunities to thrive. So thank you for being a part of this transformative movement. Thank you for keeping the fight going forward. Thank you that when you walk out this door, you're going to remember that you're a human being. Your brothers and your sisters, your uncle, your aunt, your mom, everybody, we are human beings. And we deserve the best health care. And it starts with us through mindfulness. Mindfulness. Be conscious of the moment. Did you get that training? Do you remember that? Conscious of the moment. And I want you to say this with me before you walk out the door. May you be well. May you be safe and free from suffering. May you be happy. Thank you. Same time next year? Thank you.